Greetings, everybody. Does anybody want to introduce themselves? Or say hello? You don't have to. You can remain anonymous, it's no problem. Hello, Naeem. Where are you from, Naeem? Name, did I pronounce that right? Name. And hello, Han. How are you? Yeah, okay. If you want to come on camera, Name, you don't have to. And introduce yourself, because that's part of the benefits of going to conferences is meeting people. And it's an option you can choose to use if you'd like. We start in 40 minutes. So no one's too talkative, so I'll be back. Some promotion stuff. Oh, Ahmed from Egypt, how are you? Do you want to introduce yourself, Ahmed, on camera or no? You don't have to. Oh, Dr. Bana Priva Singh from India, welcome. Oh, welcome, Ahmed from Egypt. Excellent. Great, this is going to be a good video today. Wow, we got some names. Lawton, Borba, Liu, Cherian, and all of them are giving half-hour webinars. So they're good. Usually they're 15 minutes, 20 minutes, but these are half hour. Hello, Sergey from Russia. Howard, welcome, Sergey. Sergey, you weren't the resident that was at Nepal with Ike, are you, Sergey? We start in about 25 minutes.
هنعمل تاني ميوت.
Hello, Michael, are you there?
Hello, how are you today? Oh,
Hi, John.
Today I have a lot of work.
Margarita, how you doing?
You know, it's Professor Lawton.
Good morning, Dr. Lawton.
Good morning.
Good morning.
How are you?
You're doing a fair bit of broadcasting.
Yeah, it's been quiet lately.
Oh, really?
Seems like it, but at least not like it was in the heat of the pandemic. But I think everybody's getting a little tired of this.
Well, it's kind of weeding out, that's for sure.
Yeah.
When you were doing them, I thought, geez, he ought to use his Hollywood connections. Because it's broadcasting. That's all it is. It's like TV.
I know.
And
Well,
those guys probably have some good insight on promotion and production. I mean, you produce them well. I mean, but
yeah. Well, it's been fun to do that. Some of those shows, like the base camp, that's been fun.
yeah. So that's doing well.
I think so. I mean, I haven't looked at the stats, but I think we get pretty good viewership on that.
Yeah, the brand name's great.
How are you doing?
That means a lot. Good, getting busier. But like you say, it's kind of weeding out. The numbers are slowing down. And there are certain established channels like Pakistan and Germany. There's a few ones that are continuing and taking more charge, I guess.
Mm-hmm. Yeah.
Like you guys, you guys establishing yourself. I don't have too much time. I wish I did to watch a lot of your stuff, but yeah, the field is there. It's ripe.
Yeah. Have you noticed that the numbers on the YouTube and so forth are stable or increasing or decreasing?
No, they're increasing. Well, I think, Michael, the audience has to learn and how to use YouTube, because you can interact on YouTube with the live broadcast.
Mm-hmm.
But we don't do that. The only person I saw do that is Bernie Mesco. You probably know his name. He's a big internet doc, very advanced social media. A lot of interaction goes on the YouTube. So the person doesn't really have to come into the Zoom. They just watch it on YouTube, interact and say, Michael, about this and this and this. Of course, you can't interrupt your broadcast, but I think eventually there'll be someone monitoring that YouTube, like a resident or another attending, that'll interact with them, and then will raise questions possibly during the your broadcast. Do you know what I'm saying?
Yeah.
Check it out. Check it out.
I have to say that I don't use the YouTube so much. I should use it more. Like these things that you put on, I'm sure you must have a neurosurgical TV station there, right?
Yes. Trying to get it a place where people can come to, because there's a lot of spotty advertising and notices about what's going on. It's here and there, but I'd like to have it in one place eventually.
Mm-hmm.
So let's see. Let me get up here. Well, Michael, the people are doing broadcasts, but they don't realize there's a marketing part and a promotion part. Do you know what I mean? But of course, we don't expect neurosurgeons to be concerned with that. But my experience with the techs is that they don't know how to market, essentially. But I'm sure you guys have teams of that, doing that.
Yeah, you're right. I mean, we never learn about that stuff. No one teaches us about that stuff. But
no. In medicine, you don't need to market. In medicine, it's just you just go. You just go to the webcast. That's it.
Yeah.
But-
Well, do you have sponsors on your TV?
No, I've got to get them. I mean, the big drug companies obviously are the targets. I just got to get into that community because they do. I mean, obviously they do advertise,
Yeah.
but you got to show them a product that's consistent.
Yeah. Well,
And
we got
that's,
advertising for Basecamp. Medtronic
yeah,
has been-
they do it. Why not? They do it for conferences. When you go to conferences, advertises all over the place.
yeah, and we've used that money to buy some equipment, some nice cameras, and these little things that have a track. You can put the camera on the track and roll it. So it
Yeah.
adds for some nice filming. And this is our second season, so we've raised a good chunk of money for that.
Yeah, that's great. That's great. It's the medium's television. And I'm kind of surprised that no television people have really jumped into the space to use it.
Yeah,
I'm
the
surprised.
trick
Maybe
is
it will happen, but I don't know.
The trick is to find a way to make the market bigger.
Yeah,
Our audience is so tiny. I mean, if we have a great knock it out of the park webinar, we're talking 500 people, and that's just nothing for a show.
Yeah. Well, that's why, like you say, you got advertisers like drug companies, medical device companies. They're the key. I mean, because it can't do subscription. It won't do it because the numbers aren't, like you say, the numbers aren't big. Oh, there's so let me pay attention here. What's going on?
Where is he? Is he in
Here.
Nepal?
Yeah, he's here. He just got here. Are you the first speaker, Mike?
Yeah.
Okay. Yeah, we've got 2 minutes.
Hi.
Hi, how are you?
Hey, Michael. Good to see you. This is
you.
my younger daughter here. So I was telling this is Michael, and she was asking me if it's Michael Jackson. I said, this guy is more famous.
I'm afraid I'm not, nor can I dance as well.
How you doing, Ike?
Hey, John. Good to see you, man.
I see you. But she's getting big.
Yeah, I just landed from Nepal. I just landed from Nepal a couple of hours ago. I was off-roading. So took a Toyota Hilux to task. So just landed back. Toyota Hilux. The new it's called the Toyota Surf in United States.
What is that?
It's a four-wheel drive, pretty capable one.
I see. So like an all-terrain vehicle type thing.
Yeah, it is an all-terrain vehicle. It's got a four-wheel drive, but no diff locks. It has four-wheel lows. So we were in the Everest region, Solokhumpu region. So we were driving, testing it out.
You
Nice.
ready to start, Ike? I'm sorry to interrupt you. You ready to start, Ike?
Yeah.
Okay,
I mean, Michael is starting. So you want me to introduce him?
No, I'll introduce you and you take it from there, okay?
Sure.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett, broadcasting from Miami Beach, home of Neurosurgical TV. It gives me great honor to introduce Ike Cherian put together a quick webcast just in the last week, and we have a great lineup. So I'll introduce Ike and he'll take it away. Good morning, Ike.
Thank you, John. So times are not very good at the moment. With we all remember Ukraine. In our prayers, we hope all our friends there are safe, and we also, that's just one part of it. There's a lot of conflicts going on, but then in this time, right after the coronavirus is passing, we thought we would have an academic feast with such a fantastic lineup. So we have all the stars. It's like an all-stars tournament. So, I I have a very simple task of introducing Michael. Well, he doesn't need any introduction to you guys. So, Michael, I hand the mic over to you.
Thank you, Ipe. It's pleasure to be here. Thank you for inviting me. Let me share my screen here. Okay, so can you see my title slide now?
Yes,
Yes.
perfect. It's perfect.
Okay, great. Well, great to be here. Thank you for having me. It's always a good topic, this cavernous sinus surgery topic, and I think it's worthwhile because a lot of people don't use it so much or are intimidated by it. And I think hopefully if you hang in there for the couple of hours here, you'll feel a little bit more comfortable and more inclined to use it. I'm going to talk about basilar artery aneurysms because when I reflect on my practice, that's really the main use for it. I use it for basilar aneurysms, but I would say that I don't use it for a lot of basilar aneurysms. I use it for a select number of them. And my main message is that know how to use this approach, but use it when it's needed and not when it's not needed, because it's a lot of work. There's morbidity associated with it. And, I like to feel good at the end of an operation that I applied just the right amount of force and not an excessive amount. And, if you routinely apply this, I think it's an overuse of force, if you will. And you can do so much of what we need to do at the basilar apex with just a standard approach. And for me, that standard approach begins with an orbitozygomatic. These are some illustrations that show you the bony cuts, but the upper two illustrations show you the rationale. If you look at the one to the left, when you're looking under the brain, as we do, the orbital rim gets in your way. And for most aneurysms, you can probably see what you need to see. But for the high riders, you end up not having the right vector. That green vector in this middle illustration shows you the kind of view that you need, particularly for the high rider. And so by getting into the orbital space, by taking off the orbital rim, that gives you that vector. And that's really what this is all about. The other thing is it just widens the space so that you have, a goodly amount of room. Now the bottom shows the two-piece orbitozygomatic approach, which is the one I like. By doing the blue craniotomy first and then visualizing all of the different cuts that you make, it just makes it more precise, cleaner. The reconstruction is just as good at the end of the day. So that's how I do it. These are the osteotomies. It's a series of cuts that go across the zygomatic root, across the zygomatic bone, and then into the orbit. And once those are done, you do a little bit of extra work to flatten the bone of the middle temporal fossa, take out some of the medial sphenoid wing. And then, with those extra steps, you've got everything you need. I still believe that for basilar aneurysms, the best way is the Yastrigo way, the transsylvian exposure. So I do a very wide and fairly aggressive Sylvian fissure split. It's totally benign. If you preserve the veins and respect the arteries and keep the pia intact, you can open up space that is so generous, and it really is the gateway for the areas beyond. And once you do that, there are a couple of other things to think about. You've got to mobilize the temporal lobe. That pretemporal space is so incredibly valuable. And so to get that opened up, you've got to free some arachnoidal adhesions on the basal surface of the temporal lobe. That's number two. You've got to occasionally interrupt some veins here on the front. Usually they're small and inconsequential. But once you do that, if you look at number four, that pretemporal space opens up. Key things to remember are that you can have a temporal artery here that tethers the temporal pole. And if you're not careful, you can avulse that, which is a real problem. And finally, you got to look for the anterior choroidal artery down here, number five, and really use that to guide you along that medial portion of the temporal lobe, the uncus, and free up those deep adhesions. But then you get to this kind of a view where, you've got all of the different cisterns in your space. You can communicate all the sylvian, carotid, lamina terminalis, and crural cisterns on the way to the interpeduncular. And then it becomes this wide, generous space. And then the triangles come into view, the three main triangles, the carotid optic, the carotid oculomotor, and the supracarotid triangles. And these are generally the way that you piece together the views of the basilar aneurysm that you're hunting down. And it's generally number 2 here, this blue triangle that is the workhorse triangle. So most of these illustrations here, you'll see this carotid oculomotor space, and these are the key steps. You can always get back to the aneurysm by just following your trail. And the trail starts at the carotid, you isolate your PCOM, it'll lead you to the PCA. By following it laterally, you can help to free up the temporal lobe and get lateral to the third nerve and open the space, which is good just for perspective, because you want to be looking in this way. And then you follow things medially, you follow the P1 segment, you follow the, you identify the S1 segment, the basilar trunk. And once you've got the ipsilateral anatomy here, then you can cross to the other side. You don't want to cross before you've got all this worked out. You want to stay below the rupture points on the dome here, find the contralateral vessels. And here, this little inset is the key. The perforators are what matter the most. And here you see the pathway across the front, the pathway across the back. And what you're doing is looking for the perforators, freeing them up. And in particular, looking for this spot marked X. This is the blind spot, the point where it's hardest to see, where there's almost always a perforator. It's exactly on the opposite side from where you're looking. So you have to be diligent about opening up this little zone right there. So I'm going to just show you a lot of cases, because I think the best way to learn is to see it being done. And so here's just a simple case that we'll start with. You can see it's an aneurysm that's tipped forward. This is the patient position, skin incision, the orbitozygomatic approach that we just walked you through. And this is the exposure that we'll be looking at here. So this is just a simple thing to get us started. But here, we're down in that carotid cistern. You can see the PCOM right here. These are those anterior thalamal perforators that come from the PCOM. This is actually my resident getting started here. But then as we get that in place, you can see by mobilizing PCOM medially, you have this wide open carotid oculomotor space. This is the basilar trunk. Here's the SCA below the third nerve. PCA is coming above. And it's a really nice window. Here we can look across. There's the contralateral anatomy. And as we tip the aneurysm forward and look behind, we see it's a very clean perforator strip. We only have this guy on the other side. The things on the near side are clean. So this is really, you know, your dream basilar tip, your beginner basilar tip. And it's just to sort of get us going and just show you how this really is an easy workable space. You don't need a transcavernous approach for this kind of an aneurysm. And there's a nice clean clip. If you inspect now, there are no perforators on either side of the blades. The aneurysm is still got a little bit of a beat to it. So we're going to add a second clip, a booster clip, and that reinforces things. When you see a little pulsation in there, it usually means that the tips aren't quite far enough across. You kind of lose your perspective at the very deepest portion. So usually residual means that you haven't crossed the neck fully. But there you can see that double stack and a good reconstruction across. And then, of course, icy green here to take care of things. So that's basically our first case. And it's just, you know, a simple routine thing. Now, here's a more complicated case. And this is, I showed this one because the theme here is escalation. You know, if you start off with that exposure that we were just looking at, and you find that things aren't enough, then you escalate, which means you add in things as needed. It's kind of like at the restaurant, if you're still hungry after your appetizer or after your main meal, you just order a side order or the next thing. And I think it's the same mentality with this exposure. If you get in there and you find that things aren't enough, just add things. And it's probably better to march up and escalate in that way than it is to just jump in with a full transcavernous. So here, here's a case. This is your a fairly standard broad-based basilar tip. This is a patient that was treated with coiling and flow diversion. So here's the flow diverter, here's the coil mass and the aneurysm, but you can see over time that this has compacted, the aneurysm has regrown, and she was referred at this point for us to treat. So here, this is left side because that's the side of the flow diverter. So it's a little bit different from the last case, but standard dissection down into the carotid cistern. Here's your optic nerve. Frontal lobe is sitting on the optic nerve. You got to peel this back. For this one, we're going to get into the cavernous sinus here by just, we're going to actually transpose these large bridging veins. This is an example where the veins were really tethering me, and it wasn't a good idea to sacrifice those. So I'm doing a sphenoparietal sinus transposition here. So the vein and the sinus gets peeled away. That takes me to the anteroclinoid, which is quite large in her. And now I can do my anteroclinoidectomy. The anteroclinoidectomy just gives me some additional space here. And you can see now I'm looking in the anterior or the carotid optic triangle, and here I'm going to begin my clinoidectomy. Here the bone comes out, and I'm doing this because things were pretty tight, and I just needed more space to work. So there's some fibrin glue into the cavernous sinus to control my hemostasis. Now I'm dissecting the dural ring here. And as the dural ring gets dissected, you can now see that we've opened up additional space here. This is a very large pecon. There's the third nerve. This is looking back now at the superior cerebellar artery here in the distance. And I'm needing all of these windows to bring this coil mass into view. I'm going to do one other escalation move here. I'm going to take the posterior clinoid down. So I'm in the carotid ocular motor window here. This is the third nerve here, and I'm going to also take posterior clinoid down because you can see it's really hard to visualize. So I like a 2 millimeter diamond drill bit here, and just drill that away. And with that gone, I've extended that window here in front. So there's the flow diverter. There's the coil mass. You can see the fetal PCA is right in the middle of all that, and we've got a clip using these two windows. And what I'm going to do is what I call the picket fence. I'm going to stack the clips across this coil mass and use the tips right up against the flow diverter. You can see here the aneurysm's freed. I've cleared the perforators, and I like to start the picket fence right in the middle. So this first clip starts right in the center, and the tips are right against the flow diverter, which is running here. I then create this stack of parallel clips. The tips are what I'm using to close the neck. Now I'm switching to the next triangle here. This is carotid optic, and I'm using a fenestrated clip around the coil mass to keep the closing force strong at the tip. This is the fourth clip right there at the distal end of the neck. So we've got two clips in this window. We've got 3 clips in this other window here, and this is the last of the 3 going on there. So this row of clips is closing down that recurrent part of the aneurysm. The flow diverter is left intact. The tips of the clips are right up against the flow diverter, and you can see basilar trunk, third nerve, are icy green with flow in the superior cerebellar here, flow in the fetal PCA here, and no filling in that aneurysm. There's that space that was created by anterior clinoidectomy, posterior clinoidectomy, again, creating this working window. And here I'm going to undo the transposition. You see I preserved that venous trunk by just flipping that duro forward. So you could argue that that would have been a whole lot simpler if I had just done the transcavernous up at the front, but you just don't know if it's necessary. So by getting in there first and checking everything out, I was convinced at that point that things were needed. And you can see how you can assemble that piecemeal if you need the elements. So here's a case of transcavernous from the get-go. And this was a case that you'll see was quite dramatic. But in general, I know that I'm going to need a transcavernous approach when I've got a low-riding basilar aneurysm that's below the dorsum of the dorsum sella or below the posterior clinoid. So these are ones that clearly need transcavernous to get that proximal exposure. You don't necessarily need them for the high riders, because those you can just get pretemporal and look up by changing your angles. And then for these, the more traditional, either superior or anterior or posterior projecting aneurysms, really they depend on these other maneuvers and just often depend on the size to determine whether you need the transcavernous exposure. So here's one of those. This is a kid, he presented at age 13 with a subarachnoid hemorrhage. You can see coils in his aneurysm, so he was treated endovascularly. His aneurysm recurred and recurred again. They kept putting coils and not flow diverters, but stents in him. And the aneurysm just kept growing. And you can see that this thing just was eating through his midbrain. So he was deteriorating and ultimately got sent to Barrow. And here now I've decided to do the transcavernous from the get-go. So the classic peeling of the dura of the temporal lobe here, bringing that lateral wall into view. And then we completely expose the clinoid bone here and do our clinoidectomy. So that comes out first. Here, I always use that little opening through the roof of the cavernous sinus that follows a clinoidectomy to inject our fibrin glue. And that helps with the hemostasis for the rest of the dissection. But here, with a little retraction on the dura and anterior clinoidectomy, this really opens this space beautifully so that you can begin the intradural part. So this is that Doling dural opening down onto the sylvian fissure and into the carotid cistern. You can see a lot of thickened arachnoid from his prior subarachnoid hemorrhage and his prior treatments. And as we go in, you can start to see our anatomy. This is the basilar trunk here coming into view. This is the SCA coming into view. The third nerve is here. And this transcavernous exposure allows us to mobilize the third nerve. This is the beauty of the transcavernous, is that that third nerve just becomes a barrier that's movable. And so with a little temporal retraction now and mobilization of the third nerve, you can see that things really start to open up here for us. So now, now that the third nerve is mobilized, you can begin to appreciate the basilar trunk here. You can see the tines of the stent within it. This is the PCA. So the distal end of the tines are coming out the PCA. And now we have everything in view. And so this is our working space. This is what the transcavernous gives you. The third nerve is way out here. We've got a nice working avenue here. And what we're going to do now is start isolating the complex, because we're going to need to open this up. This is a thrombotic aneurysm. Coils are in there, so we've got to soften this thing so we can clip reconstruct. So this is the first clip on the basilar trunk. The next clip goes on the P2. We then clip the SCA. Ipsilateral, you can see it's a duplicated SCA there. And reaching across, we'll put another clip on the contralateral SCA. So these clips trap but not completely isolate the basilar apex. And now we can open it up. So this is an aneurysm incision here, high into the fundus. And I go in with my CUSA, and the idea here is to take out the thrombus that's around the coils, leave the coils alone. There are too many to extract. You don't need to extract them. But you can see that that maneuver softens this thing. And it's converted this aneurysm from a solid tumor into a workable sac. Now, it's a giant aneurysm and a very large neck, so we need fenestrated clips. This first fenestrated clip here is to kind of gather the neck and close it up. So the blades here are going on either side. And this clip is not long enough. It's the longest fenestrated clip you'll find, but it's not long enough to get across, but it gets us going. We then come in with the second clip, and you can see this is like a tandem construct. I'm using that incision into the aneurysm to advance this further, and that gets me all the way across the neck. And now we just need to close the fenestration. So I'm going to place clips across my arteriotomy here within the fenestration itself, and that closes up the spot that we've opened. And now the opening has been closed, the aneurysm has been reconstructed, and we've preserved our branch anatomy here. So this is our final view. Show you the icy green here in a moment right there. So good flow in the basilar trunk, the SCA, the PCA here. This is the contralateral SCA. And once everything looks good, we can go in and do our thrombectomy and remove even more mass effect. So that's the before and after shot. You can see a nice reconstruction there. This aneurysm was finally cured. And here he is on his way back to Europe before finishing this up. So next case I wanted to show you is this one. This is an example, not so much of transcavernous, but a similar giant aneurysm that, you know, sometimes the transcavernous and clipping approach isn't the best way. This was a lady from Israel who had an aneurysm that looked like that in 2020. A year and a half later, it had grown into this. So rapid conversion into a giant aneurysm. This is what it looks like here on CT angiogram. You can see she's got some pathology with other aneurysms, but one P1 is coming out here, the other over here. This is a clearly dolichoectatic aneurysm. It's giant in size. What are you going to do for this one? This isn't an exposure problem. This isn't a problem of doing a transcavernous and seeing everything. It's a problem of how are you going to address this? And the way that I chose to address this was with flow reversal. So a bypass from the M2 down to the P2, a Hunterian ligation of the inflow to the aneurysm, and a flow reversal. So here's the view. We're going to go on the left side. This is a view down the Sylvian fissure. This is the aneurysm here. There's the third nerve. This is the PCA coming out of it. So what we're going to do is do this M2 P2 bypass, and I always do the deep, more difficult portion first. So this is our radial artery graft, and we're going to sew that into the P2 segment. So even though this is a deep corridor, she had some anatomy that brought this into view very nicely, as you can see here. And this is completing that anastomosis. So this is the distal end. Now we bring it up to the MCA. This is the proximal end, or the donor site in the Sylvian fissure. You're there anyways, so there's really no need to go down to the neck. You can use the M2 as your donor. And this is now doing our donor anastomosis. Here's a view halfway through at the inside of the suture line. And now we finish it off. So now you can see a nice bounding bypass. This actually needed some work. We had a problem with the graft and needed to redo that. I think that's part of the video here, but this is the Hunterian ligation on the inflow side of the aneurysm. And this is what we do. This is, here was the problem. You see the graft has, as it turns out, has an occlusion. So we've got to redo the bypass. You can see thrombus had formed inside. It really wasn't a problem with the anastomoses. There's the anastomosis. It looks beautiful. So I'm going to use that little cuff to redo the graft. We had her whole radial artery, so I had enough graft in reserve to just do this over again. So I do it over again. I'll just jump through that. Here's the anastomosis of the MCA, or the donor side of that. And so now we finally have a good working bypass. So there it is. And once that's in place and we're completely confident that things look good, we go back on there with that Hunterian clip on the basilar trunk, and everything looks good. Now here you can see, this is the bypass retrograde filling the aneurysm. You see that jet of flow into the aneurysm. That's our flow reversal down there. And so we've achieved our flow reversal. And what's interesting is that when you do that, here's that double interposition graph with the cuff there and the other graph that jumps around. There's the aneurysm in the distance, the third nerve here, dissected along its course. This thing is now going to go off and thrombose. And let me just show you that. So here's what the angiogram looks like. The red arrows show you the M2P2 bypass with a little bit of retrograde filling there, a little shadow of the aneurysm there. And over time, literally days, the rest of the aneurysm clotted down. And you can see that on the CTA. Let's see, do I have a picture of that? No, I don't have a picture of that. But this thing shut down. So it thrombosed down, the flow reversal worked, and we did lose a little perforator in the process. But that was essentially the only downside. And she overall tolerated that really well. So this is, let me just very briefly in the last few minutes here, just show you this, because this shows you the transcavernous. This was the same idea of flow reversal, but in this one, I'm gonna actually use the transcavernous. This is the aneurysm. It rides very high above the bone. So what I'm gonna do is use a Kawase approach, transcavernous exposure, to get to this part of the aneurysm. So let me just take you there. This is the part of the anatomy that I want to get to using my transcavernous exposure, the two vertebral arteries that feed into this. And so let's jump to the view here. This is the transcavernous part of the exposure. We do our clinoidectomy. We inject the cavernous sinus. You've seen that before. This is the patient had a pneumatized optic strut, so that was the yo-yo technique and taking care of that up front. This is the anterior clinoidectomy part of the case here. So we take care of this, and now we're doing our intradural subarachnoid part of the dissection. So this is our anatomy. These are the arteries around the apex. Here's our third nerve. Our aneurysm is down there at the bottom. And so this is the artery coming out of the aneurysm. The dolichoectatic aneurysm is here. And this is where we do our Kawase approach. So our incision in the tentorium opens up into that bone that's been drilled extradurally of Kawase's space. This is the fifth nerve here. We do a little bit of extra drilling here to get into that working space to find our vertebral arteries. And now we've opened up just enough space to get the job done. These are the verts now feeding into the aneurysm. We're going to do the bypass next, and I won't show you that because you've seen that plenty of times now. So this now is the bypass after we're done. So it's in place. We've got distal flow. Now we're going to turn our attention to the Kawase window. This is the vertebral artery. It's a massive vessel, but we can close the ipsilateral vert with our first clip. This is the Kawase space underneath the fifth nerve. Now, what I'm using here is a rapid ventricular pacing to soften things, and I can get my clip on the contralateral vert. So they're the two closing clips. Here's our bypass. We've got all of those windows opened up here. And so we've got proximal aneurysm occlusion, distal bypass, flow reversal, stagnation of flow in the aneurysm. There's the third nerve running across. And again, this is a strategy for changing the flow dynamic and promoting thrombosis, which is ultimately the best and really only way to protect this patient from future growth. There's a nice view of Kawase's space, the traditional basilar corridors here, and bringing all of those together in one surgical view. So with that, I'm going to finish up here. These are unforgiving aneurysms. I think most of the world has moved on to come to these conclusions that coiling is the way and that endovascular therapies are superior. I would argue that that's not the way we should be looking at this, that there are these monster aneurysms out there that just aren't well suited for endovascular therapy. I acknowledge the learning curve. This is from an early paper of mine. It takes a lot of work and diligence to get your skills up to this. These are my numbers. I've been at this now for 24 years, a lot of aneurysms, and you can see I'm almost at 500. But still, the M&M here is tough to beat. This is an unforgiving area, and you just got to keep working at those numbers to try and whittle them to zero. So these are my concluding thoughts. I do think there's a role for microsurgery with these aneurysms. Endovascular therapy has taken over the simple stuff. That technology, that modality, I think, is cherry picking the field. But we need to be ready for the complicated stuff, the kinds of things that I've been showing you here. When the endovascular therapy fails, when you've got the dolichoatasia, when you've got the real ugly, giant thrombotic type aneurysms. And I think there needs to be enough of us out there who do aneurysm surgery at the basilar apex who can be ready. So with that, let me unshare and thank you for having me.
Well, Michael, what you've shown is just remarkable. It's combining skull base and vascular to the highest level, and I hope the young people seeing this has somebody to look up to, because this is exactly what we've been telling. The expertise and the passion and has been going down so much that sometimes it's difficult to to call our trade neurosurgery when even a magician has more tricks up his sleeve than a neurosurgeon. So it's you are an exception. This is truly something which is not seen commonly. So I can only say take a bow, Michael. So thank you very much for that beautiful presentation. And
thank you.
We will ask questions and all after the presentations are over. So I'd rather go with the second presentation. I suppose it's mine, but if anybody wants to do it early, I mean, if there are Japanese, I mean, is Samishima here? I mean, his presentation would be 2:30 in the morning for him.
See here. Dr.
Is Samishima around?
I don't believe he is. I haven't
Yeah,
seen
because
him.
Tetsuro told me, messaged me and said that he's got a big case tomorrow and it'll be 2:30 a.m. for him in the morning. So when his presentation starts, so it's kind of weird. You don't want to do a presentation at 2:30 in the morning and go to the theater next day. So in that case, I'd start. And the next after that is Hira or Hira here? I mean, I think not.
No, she's not. But
okay. So I'm going to start my presentation. I mean, it's very difficult presenting after Michael, but I'll try my best what I can do. So let's see. So I'm going to talk about Transcavernous approach for the beginners. So what is the objective and how do you achieve transcavernous? So Michael had so clearly shown. Now, there are a few things that one needs to understand before going transcavernous. And one of the things that you need to understand is how do you unlock the brain? So there are these unlockings that we've described. We will talk about it more. And then the second thing that you need to understand is the ICA segments. So the extradural ICA segments. Then you will have to understand how do you do an extradural pericavernous dissection. And then after this, after you've done that, then you need to understand the right technique for an anterior clinoidectomy. Of course, a posterior clinoidectomy is also very useful as sometimes, as Michael showed, and we'll be showing that also. And then how to use the transcavernous corridor, which means you open up the space between the third, the fourth, the V1, and combine it with the anterior clinoidectomy, the clinoidal space, intradural and extradural. So you open up. Yohei Mura, I'm sure he'll be showing some of those cases as well. So Jim Liu is here. He'll be showing up some cases as well. So Borba had just messaged saying that he had a case, so he'll be joining back later on. Ashish, I hope, is here. So we will all be showing these cases. So here is how we start the unlocking. So the brain in the sagittal plane is, the sagittal plane has to be unlocked. That is the first thing. So for sagittal unlocking, the first thing that you do is sphenoid ridge drilling. So after you drill the sphenoid ridge, you won't believe, just by doing drilling of sphenoid, this is something that all the neurosurgeons do. And just by doing diligent drilling of the sphenoid ridge all the way up to the superior orbital fissure, the kind of space that you will free up at the skull base is amazing. So that's what you are doing first. And second is you have to go to this area where the frontal lobe, the temporal lobe, and the orbit is joined by one dural band. And that is the orbitomeningeal band. So you need to dissect that very carefully under the highest magnification. And then you'll be able to peel the temporal lobe posteriorly on the cavernous sinus. And you can also peel the frontal lobe away so that you can see the extradural optic nerve. This is a big step to the base, okay? And so this is the second step that you need to understand. And after you've done that, so this is how you must be peeling. When you are dissecting the orbitomeningeal band, this is how you must be peeling. In fact, you can do either transcavernous or pericavernous. Transcavernous is required when you use the cavernous sinus as a corridor. Pericavernous is required when you just need to unlock, which means you have to take the temporal lobe away. And that's just unlocking. So you don't need to expose all these cranial nerves, and you don't need to have this bleeding. So we will show you that as well. So this is the pericavernous bloodless dissection. And of course, this is the cavernous sinus. So now the key to this cavernous sinus is, first thing first, you'll have to understand the ICA segments around the cavernous sinus and their branches, and then the cranial nerves and the other structures associated with them. This is very, very important. If anybody is doing cavernous sinus surgery, it's extremely important, because triangles such as this, where you are behind the carotid, you are literally in the cavernous sinus, you have the meningohypophyseal trunk here, you have the sixth nerve, Dawlings here, the sixth nerve here, and this triangle with the ligaments is extremely important, and you have to understand it in relation with the carotid. You have to understand this triangle where you are between the fourth nerve and the V1, and you can see the infralateral trunk, and you can see the C4 segment, the horizontal segment. All these, you have to understand the exact relationships of the carotid with the cranial nerves, with the cavernous sinus. It's very important. So, and then using the transcavernous corridor is when you cut the dura, cut the tend, release the cranial nerves, and then make the space into one large space. So you can cut between the fifth and the fourth, and the fourth and the third, and then between the I mean, between the third and the optic nerve, you can release the entire third nerve, either from intradural to extradural or from extradural to intradural, as Michael was showing in some of his cases. So we come to the concept of why we need to unlock the brain. This is because the brain is folded both in the sagittal and the axial planes. So once we unlock the base is where your basilar tip aneurysms are. The base is where your craniopharyngiomas are. The base is where all your skull-based tumors are. So that's why you need to unlock. So sagittal unlocking starts off with sphenoid ridge drilling. So once you drill the sphenoid ridge, you can cut the orbitomeningeal band there, and that is where the axial unlocking will start. So that's the V2 there. Once you cut this and develop a plane here, you can take this temporal lobe back. So once the frontal lobe was like that, you want to take the temporal lobe back. So you see the cavernous sinus with all the nerves there. You see the cavernous sinus, and then you can take it back, and then you get a clear, with not a lot of distractions, you can get a clear view into the interpedunculair space. So that's exactly what we're doing. We're cutting the orbitomeningeal band and taking the temporal lobe away from the cavernous sinus. So this is called axial unlocking, pericavernous dissection. So here you have managed to take the temporal lobe away as much as possible. So you have V1, V2, V3. We've done the axial unlocking right now. So then you have the cranial nerve 2, cranial nerve 3, then the 4 crossing over the third nerve. Then you have V1, V2, and V3, and the multiple windows. You want to choose a transcavernous corridor, you can go in through these windows. But if you just want to unlock so that you intradurally you get a view towards the interpedunculair cistern, that's also good. Now, another step you have to understand is the anterior clinoid process resection. Why do you need to do anterior clinoid process resection? That is primarily because you have to get space. The clinoidal space is very, very important for you. I will tell you that is for some paraclinoidal vessels, this is very important, but sometimes even for the basilars and posterior fossa pathology, it's really important as well. So that is the ACP. So, and sometimes the PCP resection is also very important. As you can see, this is the optic nerve. These are the two perforators, and that is the posterior clinoid process. That's the posterior clinoid process exposed, and this is how we drill off the posterior clinoid process for space. And now I'm going to talk to you about understanding the extradural ICA segments. Yeah, so the extradural ICA segments, I usually use a graphical cartoon representation of them. I'll be coming to that again. But you have to understand that there are 3 vertical segments and 3 horizontal segments. That is all you need to understand. The 3 vertical segments from anterior to posterior. First is the C3. That is what the ENT surgeons or the endoscopic surgeons, the neurosurgeons, endoscopic surgeons, they see first. That is called the paracellular segment. And then you have the paraclival segment, the second vertical segment. And then you have the parapharyngeal segment, which is part of it is in the neck and part of it is in the pittus bone. So you have paracellular C3, paraclival C5, and parapharyngeal C7. Okay, so these are the three vertical segments. Very, very important for you to understand this part very clearly. So in an endoscopic view, you are going to see the rest of it is end on for you. So you're going to see only the vertical segment, that is paracellular, paraclival, and parapharyngeal. Now you have also 3 horizontal segments. That is the C2 is a horizontal segment which is intradural, which is beyond the distal dural ring. Then you have the horizontal intracavernous part. It may not be very straight after all. It may be, sometimes it may be a little bit more vertical than this. And of course, the petrous carotid. So you have C2, C4, and C6. These are the even numbers. Even numbers, they are horizontal, while odd numbers are vertical. So C3, paracella, C5, paraclival, C7, parapharyngeal, C2, intradural carotid, C4 is horizontal intracavernous, and C6 is petrous carotid. Now, if you understand this, half your job is done. And after that, you just have to understand that C2 is related to optic nerve, C3 is related to third and fourth and V1, and C6 is related to GSPN. This is the facial nerve. That's a cochlea. That is the semicircular canal. C6 is related to the GSPN, and anterior to the cochlea is the C7 dip. The C7 goes down anterior to, just anterior to the cochlea. So if you see that the C5 paraclival relation is petrolingual ligament, the 5th nerve, the 6th nerve, and these relations, as you go forward, you can build. You can build these relations, and then that helps in your surgery. If you're going intracavernous, this is the anatomy that you need to know. So as I said, you have C2 intradural, C3. Just let me change this. Yeah, move this away. Yeah. So you have C2 intradural, which is horizontal, C4 cavernous, C6 petrous. All of them are blue. Now you have vertical C3, C5, and C7. They are in red. So this is the anatomy of the extradural carotid, and it's really, extradural and intradural carotid, and this is very, very important to when you are considering a transcavernous approach. Now, I've just put in the relations as well. So you got anterior clinoid process here. So when you're taking the anterior clinoid process, your strut, your optic strut is in fact in front of the C3. In front of the C3. Okay, you have to understand when you're drilling the optic strut, you have to understand you're in front of the C3. When you're taking the anterior clinoid process, you are actually on the C3, C2 transformation, where the distal dural ring and the proximal dural ring comes. And just below the ACP, you will have the roof of the cavernous sinus, where your cranial nerve 3 is coursing. Cranial nerve 4 is also coursing there. Then you have C3 and you have C4 and you have V1 there. So between the 3rd nerve and the 4th nerve, you can expose this horizontal carotid, horizontal intracavernous segment. And between the horizontal and the C5 paraclival segment, you have the meningohypophyseal branch. This also you can expose by developing a Parkinson's triangle. If you develop, you can expose the meningohypophyseal trunk. And when you drill PCP, you should clearly understand that your C4, C5 transformation is actually anterior and inferior to the PCP. That's very, very important for you to know when you're drilling the PCP. That's a clivus, that's a paraclival carotid, that's a petrous, which is running parallel to the eustachian tube, and the GSPN. And then you have V1, V2, and V3. You have cochlea, and anterior to that is your C7. So that is the anatomy that you can see right now. You can see the petrous carotid. You are seeing the GSPN there. That's a petrolingual ligament. That is the 6th nerve medial to the V1. And you have C5 horizontal. You have C5, which is vertical. C4, which is horizontal. C3, which is vertical, and then C2. So this is the anatomy. When you're going transcavernous, this is the anatomy that you cannot afford to miss. I mean, if you don't learn this anatomy, then going transcavernous is going to be difficult. So when you're going, when you're getting a side vision, see that this is the C5 paraclival carotid. This is a horizontal intracavernous carotid. That is C3. That is the vertical carotid, and then C2. So this is. And so now we're going to show you where we are using this approach in a paraclinoid aneurysm. So here is a paraclinoid aneurysm. It's a ruptured aneurysm. So you can see that that's a clinoid process and that's the aneurysm. So if you can see the clinoid process, the planum there, that is the carotid and that's the aneurysm. This aneurysm is ruptured. So this carotid is coming. This is C4, C3, and C2. And this aneurysm is transitional. It's going into between, I mean, it's a transitional aneurysm. It's between the dural rings. So you need to open the dural rings here. You need to drill off this clinoid. And since it's a ruptured aneurysm, it's drilling on this clinoid right next to this ruptured aneurysm is going to be a bit of a issue. So we're going to start there. Yes, so as usual, we are doing the, opening the orbitomeningeal band. Proceeding on the orbitomeningeal band, slowly pulling that temporal lobe backwards, uncovering the clinoid there. That's a cavernous sinus. We preserve the membrane over the cavernous sinus so we don't have bleeding there. So now we put in the retractor there and on the frontal lobe, and you expose the optic nerve and this clinoid, drill off the clinoid there. Now you define the clinoid. You've got to be very careful because the aneurysm is right there. So you've got to be really careful, and then you drill this clinoid very thin. Keep on drilling this clinoid. You use a 2 millimeter diamond drill bit, and that's the cavernous sinus there, and that's the optic nerve. So that's the space that you get between the optic nerve and the cavernous sinus. You make this clinoid paper thin, and then you'll be able to mobilize the carotid. I mean clinoid. As usual, usually we just take the carotid. I mean, even before it is much thinner, we can take the clinoid out, but not in this case because you really don't want, it's a ruptured aneurysm and you're doing it extradurally. You really don't want to, pull or push there. So you are making it paper thin. You can literally see the aneurysm there. That's the optic nerve there. That's the optic nerve there. And that's the aneurysm. So you are using, under very high magnification now, you're using a 1 millimeter drill bit. And you're drilling the optic strut there. That is a optic nerve there. That's a strut anterior to the C3, anterior to the C3. That's important for you to understand that. So now you can clearly see that's the optic nerve, and that is the aneurysm. And we are using a smaller drill bit there to further take off the strut, paint it. You just have to be, you just have to be painting. You cannot put any force there because it's the dura which is protecting you against the ruptured aneurysm there. So you are keeping on taking it out gently, furthermore, taking it out. And once you have drilled all that, then it becomes easier for you because you can just cut the dura over all the way over the optic nerve and then down. I mean, from the falciform ligament down, all the ligament. I mean, if you take the proximal and sometimes even the distal dural ring, I mean, sometimes mostly the distal dural ring and sometimes the proximal, if you can take that out, then you can clip this aneurysm without much issues. So that is what is happening right now. So I'm taking off the strut right now. That's your optic nerve for orienting you. And that's the aneurysm again. That's the aneurysm. We will, as soon as I open the dura, you will understand how this aneurysm is looking. So we'll take off the optic strut, all the optic strut that you require to get down. Now we are opening the dura. Opening the dura there, releasing all the adhesions. And you have the optic nerve now, you have the aneurysm right there. So all this part we have drilled away. Anterior to this aneurysm, we have drilled away all this part. So it becomes much more easier for us intradurally to handle this aneurysm. So after taking off the arachnoid adhesions, I am using a diamond knife to cut over the lateral part of the falciform and then convert that falciform cut, take that cut down and then find the distal dural ring and then cut the distal dural ring and then get control of this aneurysm. So I excise, open the falciform ligament and I take it laterally. You can see the aneurysm here, this aneurysm. Intradurally, without this approach, it's almost impossible to clip this. So you are now cutting the distal dural ring. Once you incise the distal dural ring, now I show my residents as to this can now be clipped because you can see the C4 carotid, the C3 carotid, and now you can clip it. So we are going to go parallel to this C3 carotid and clip this aneurysm. So you can see the C2 carotid there, the C2 going and transitioning into the C3 carotid there. This aneurysm was extremely thin-walled. You can see the blood swelling in there. So we were a bit, and it had already ruptured intradurally. So we were looking for the rupture points as well. Now we are going to put in a clip parallel to the carotid. This is very difficult because you can easily go and occlude the carotid if your clip is cross. And if your clip goes across, you can clip the carotid. You have to see the carotid going into the C3. And it's possible only after dissection of the distal dural. You can see now this carotid, you can see that carotid. It's in the cavernous sinus. It's going into the cavernous sinus. So that's a carotid going, that's a vertical carotid and that's a horizontal carotid. And that is, now there is a small dog ear here, which you can settle by just applying a clip there. Yeah, so you can see the vertical carotid here, the horizontal carotid here, and then we are done now. I will be happy to show a few more cases, but then yeah, this is another simple posteriorly projecting basilar. This will be my last case, and after that, the next speaker can get ready now. So this is again a small basilar tip aneurysm. So we are doing the same dissection. We are doing the anterior clinoidectomy here, and after the anterior clinoidectomy, we are dissecting and getting this opticocarotid space. This is a ruptured aneurysm again, so it's rather tough arachnoid membranes and a lot of blood. So we are going between the optic and the carotid. We have developed the third nerve space also. So we have to see, on the basilar, we have to see the contralateral third nerve. This is how I always find. So in posterior fossa surgery, one of the truths, always the truth is that is the third nerve. If you find the third nerve, superior cerebral arch, whether duplicated or not, they are always below the third nerve. and above the third nerve is the PCA. That's the basilar trunk, that's the PCA, that's a contralateral PCA, and that's aneurysm going behind. So when the aneurysm is going behind, you have to always be careful, because that's a ruptured aneurysm. You have to dissect and make space between the two, between the P1s and this aneurysm. So you have to spend a lot of time trying to coax this aneurysm to come out of that space between the P1. It's like a, it's like an armpit, and you need to coax it out slowly, very gently. I mean, no motions that will show power. So here it's you have to be very, very gentle and patient, and slowly coax that aneurysm out of that P1 basilar junction. So it's posteriorly projecting. So you have to, of course, as you have to look for all your perforators and make space there and look in there, see, and sometimes softening this aneurysmal dome helps. So we use adenosine in between, so that I can soften and dissect further. I don't believe in putting a proximal clip. I mean, I know Michael has a lot of experience, but we've had some bad experience with putting a proximal clip, and this is probably why I don't. I mean, unless I'm really pushed to, I don't put a proximal clip. I rather go for adenosine and softening, or even if it ruptures, I go for adenosine and arrest and then clip. So so we keep on dissecting the neck further and further and further till we can pass the clip and clip it, so that you have P1, you have superior cerebellar, and the third nerve on this side. This is the opticocarotid window. This didn't really require a transcavernous, although we had prepared for one. So, and of course, as you can see, the ICG. I'll stop sharing now. I hope, I mean, all the questions we can wait for afterwards. And the next speaker, I would be happy to welcome the next speaker. Who's speaking next? Is it Johe?
There's Dr. Muller and Dr. Suri are here. I don't know
Okay.
which.
Johe, you are scheduled to be next, or Jim?
I'm next.
You are next, Ashish. Okay.
Yeah.
So Ashish is one of my old friends, and he is a professor, and I believe the chief at AIMS right now, Ashish. So he's the chief at, I mean, he's one of the best skull-based surgeons in this part of the world, maybe one of the best in the world as well. So I would be happy to have him over. Ashish, please present your stuff. So we have, next is Johe, and then next is Jim, I suppose. After Ashish?
Yes, it will be me after Ashish.
Okay, okay. All right.
Yeah.
All right. Good to see you, Jim.
Thank you,
Right.
Api. And can you see my slides? Am I
Yes,
audible?
yes. We
Yes.
can.
Yeah. Thank you very much for the kind invitation. It was a pleasure listening to both Dr. Lawton as well as you, and waiting for others. This is, like Dr. Lawton said, Transcavernous Approach. I learned from Vinko Dollins and also then Kawase, and it's a beautiful approach. It is a very painstaking and a very beautiful approach, and this is where I find that it can be modified into a rhomboid in which you can deal the petrous apex into it. This is where I work, the AIMS New Delhi, and it's one of the biggest programs in the country. And this is the area which I'll be talking about, the middle fossa, and the corridor, the shortcut from the middle fossa into the posterior fossa. That is the most important area. So we'll be talking about the cavernous sinus and the relation to the petroclival area and the petrous apex and the posterior clinal. Most of it will be centered around the cavernous sinus, the posterior clinal process, the petrous apex. This is a pretty crowded anatomy, like Dr. IP nicely delineated the anterior clinal process. I'll be talking more about the V1, V2, V3, and the posterior clinoid and the rhomboid, and how it This is more of an extended temporal approach. And the main idea is a posteromedial. This is a posteromedial approach to the Kawase rhomboid. I'll just very sharp, rapidly show up the section so that you're acquainted with especially the youngsters. So this part of skull base, it is not head and neck surgery. I always tell my residents, it's just a minor modification of a pterional craniotomy. That is the anterior part, which Dr. Lawton and Dr. Ipe nicely mentioned. And the extended temporal approach, I'll be talking about more. It's more of a modification of a temporal craniotomy. So it's not head and neck surgery or a massive skull base surgery. These are minor modifications with unlocking of the locked fields. So this is where we go down and peeling of the anterior cavernous sinus. I mean, you can see the V2, and that is the periorbital fissure unlocked. And this is always a combination of blunt and sharp dissection. And that is the anterior clinoid process. And you have to drill it you're drilling like a pyramid, the base of the pyramid. You're not supposed to drill the ring. So you have a vision directly onto the optic canal. And that is the optic canal. And you actually take the tip out and then dilate the foramen spinosum, coagulate and divide the middle meningeal artery, and then that's the V3, and that is the separation of the V3. So if you're talking about access to the posterior fossa from this area, because this is the one which is important. So we are not interested in the anterior clinoid process when you're going into the posterior fossa, especially unless you're talking about the optical carotid cistern or the basilar area. Here, our main axes are the crural cisterns and the ambient cisterns. And that is the rhomboid, the Kawase rhomboid. And this is the wide Sylvan fissure opening. And that's the two optic nerves, the lamina terminalis. And that is what Dr. Michael showed, the Transcavernous approach, and with the temporopolar modification. And then the opening of the distal ring, the proximal ring, and then the posterior part, the tentorial section, opening of the posterior fossa dura. And here you can mobilize. This is the important thing about why transcavernous, because then you can mobilize this trigeminal nerve from the gastric ganglion, and actually you can go in front of it, behind it, and you can drill some more petrous apex. And so you can see the sixth nerve anteriorly. That's the most important nerve that can be injured. And posteriorly, you can see the 7th, 8th complex. And then you can go into the cavernous sinus. Well, but it's a standard pterional incision if you're more of anterior centric approach, or a temporal incision if you're more of a posterior centric approach. That there's a mild head rotation, that the more you go posterior, the more rotation would be there. I always combine an OZ, or orbital zygomatic, with pterional craniotomy and just a zygomatic osteotomy with temporal craniotomy. So usually a two-piece, if it's a zygomatic osteotomy, most of my zygomatic are single piece. So what is the aim? The aim is, this is the standard Kawase triangle. This is the GSPM, the arcuate eminence, the petrous ridge, and that is the V3, and that's the gastric ganglion. But if you peel off the whole of the cavernous sinus there, you actually convert it into a rhomboid, and you actually straight right at the apex, and you are actually away from the gastric ganglion. Sorry, not the gastric, the Glasgow triangle and the ICA. And this is our paper in which we did a volumetric analysis of a rhomboid versus a triangle, and we found that the rhomboid with transcavernous modification was nearly 2 to 2.5 times more area and volume than the standard triangles. This was published several years ago in CNS. And this gives a bigger approach. The only difference is it actually mobilizes the 5th nerve. When it comes out from the triangle. It gives a spectrum of wide spectrum of conditions that can take care. Extradural conditions like chordomas, chondrosarcomas, angiofibromas, coming from the nasopharynx between the V2 and V3. Intradural conditions like a dumbbell schwannomas, and intradural a petroclival meningioma, or a basilar PC aneurysm. This is a petroclival meningioma. These are many of them, and these are the most humbling tumors which I find in neurosurgery. You cannot predict how your surgery will go. You cannot predict when you will come out of your surgery. And most of the tumors, if they're going medial to the interolateral canal, it is extended subtemporal. That is the modified Kawase rhomboid approach. If they're going much lateral to the interolateral canal, I combine the retrosig approach along with it. I do not do any complete petrosal approach. Now, this is a case in which I'll do a combined approach, anterior subtemporal and extended subtemporal along with the retrosig. So this is a large petroclival meningioma. It was tried operating at another center outside, and then we went in. Oops, sorry. Yeah, so a temporal craniotomy with a zygomatic osteotomy. Temporal based drilling. I'll just forward the videos. And then a basal dural separation. And that is the middle meningeal artery, coagulated, divided, and then the V3 separating right from the superiorbital fissure till the GSP, and you have to peel. That is the exposure of the rhomboid. And now you see this is straight drilling right on the rhomboid. And then after the posterior fossa dura is, then the temporal dura is open parallel to the base, and then a T shape down it goes, and that's a tentorium. Cut the tentorium 1 to 1 centimeter behind, 8 to 10 millimeter behind the fourth nerve exiting, and then we're directly on the tumor. And that is superior petrosal sinus, which is divided. And then we decompress the tumor and dissect it off the basilar perforators. Posteriorly, you have to be careful that you're dissecting it off the 7th, 8th here in this, and anterior medial, inferiorly, it's the 6th nerve. So the best thing is I give the suction to my assistant, and I take 2 very fine forceps so that we can dissect it. And that was the 4th nerve. 4th nerve gets stretched by the tumor. It is not very unforgiving. It doesn't, but yes, the place where it can break is where it's exiting from the tentorium. And that is the dissection from the 5th. That's the 5th nerve you can see. So you're going above and below the 5th nerve. And that I think should be the 6th. And the basilar perforators. Most of the petroclival meningiomas have an extension onto the cavernous sinus and the tentorium. So with this approach, you can actually take off the tumor, and then a primary closure and a commensurate fat graft and fissure. And that is the postoperative scan. You can see that little tumor. So now this is an old series. There's more than 160 odd cases, personal experience, and 42% gross total excision and 24% near total. And I'll not go into the details of the preoperative and the new deficits. This is what we found, that the brainstem compression, brainstem edema, absence of an arachnoid plane, T2 hyperintensity, and the tumor on the MRI were predictors of poor outcome. And on multivariate analysis, it was 282 hyperintensity in the arachnoid plane. Nearly 68% of patients did well, 28% was same, and 4% worsened. Just go to the next. Oh, sorry. And this approach can be used for chondrosarcomas. As you can see, it's a direct approach, extended middle fossa and chordomas. So this was the part we went through extended middle fossa. It's very good bimanual dissection over the arachnoid and over the perforators. The one which is going through the sphenoid, we use the extended intranasal approach. That is a petroclival chondrosarcoma with a lot of calcified component, an old lady. So again, that is the foramen spinosum. We coagulate and divide the middle meningeal artery. Feel the two layers of the cavernous sinus and drill the rhomboid and then the dural opening. And that is the calcified chondrosarcoma that is there. And we use the bone cursor to remove this. And that thing dangling in the middle is the fifth nerve. And you can see it was as solid as a rock. The only way to take it off was thin with the bone cursor and then dissect it from the perforators. And that is the tumor completely removed. And sixth nerve also preserved. That is. And we seal the sphenoid part of the opening. And because I was intact with fat, and then close the primarily. And these are done such two cases with giant complex P2 aneurysms. We did a STA-PCA bypass, and this was taking of the anterior petrous rhomboid was very good, so that we can actually go straight right to the P2. So as you can see, there was no P1. It was a complex P2 aneurysm, failed embolization, harvested the superficial temporal artery, both the branches. Then we went down, we did a temporal craniotomy and zygomatic osteotomy, then peeled the layers of the cavernous sinus, and that's the petrous rhomboid. Drill that, and that's the posterior fossa dura, and that's the middle fossa dura. So the dural opening is parallel to the tentorium, that's superior petrosal sinus, and then that is the superior petrosal sinus. And there's the opening of the posterior fossa dura, and that's the tentorium, and that's the fourth nerve. So once you take off that part of the rhomboid, it's the shortest approach for the STA to go down. And then that's the PCOM is entering into that tumor, the aneurysm, and that is the P2. And so one branch was enough. We already had two, and we do an end-to-side bypass. Continuous sutures because they are deep. And check with ICG and Doppler, and then we ligate. We put a permanent clip on the PCOM so that this aneurysm, and also prepare before the aneurysm so that it can close off. Basilar aneurysm, especially a low-lying. This is an old video. I'll just skip the temporal drilling. This is very important. When you can actually cut the tentorium at two places. One behind the fourth nerve, that is so that you are actually opening straight into the superior petrosal sinus. That is the posterior fossa dura. So that is the leaf of the tentorium that you create behind the fourth nerve. After that, fourth nerve you cannot actually mobilize. Once it comes into the out of the tentorium, you can. That's the third nerve. This is another triangle that can be opened. That's the oculomotor triangle, trigone. You can open it by around 7 to 8 millimeters. If you do not open it, your third nerve is unforgiving. If you stretch it, it'll never come back. And then you have place for a temporary clip, and then identify the P2s, and under a temporary clip, a water bath coagulation. Make a neck. Do not try to apply a clip straight away. And that is. And we used it for dumbbell-shaped schwannomas with half of the predominant tumors going, and you can see the most of the petrous apex is amputated, eroded by the tumor itself. So it's a small temporal craniotomy, zygomatic osteotomy. Again, we go down, we drill off the petrous rhomboid. Once you've done that, then we open the rest of there's an interdural approach. The moment you strip off the dura and you have the tumor there, and then the rest of the petrous rhomboid. So now we decompress. These are much more tougher tumors than a vestibular schwannoma. So you actually have to decompress and dissect it and find the fascicle where the tumor is actually coming out from. Fifth nerve is a big nerve and has multiple fascicles, especially in the gastric ganglion. So you have to actually find the fascicle if you really want the patient to improve the sensations, and dissect it off all the surrounding nerves, and then you actually find the fascicle and divide that. So the rest of the fascicles are normal, and then you look at the posterior fossa. We've used the approach for multifunction. This is approach which I use for a multi-compartmental epidermoid going to the opposite side. It's the standard nice approach. A small temporal craniotomy. This was an epidermoid with bilateral CP angles and bilateral suprasellar cistern. So you're actually going transcavernous, anterior petrous rhomboid is taken off, temporal durotomy, and then incising the dura, we've divided the superior petrosal sinus. That's the superior petrosal sinus also divided. So you're opened, you make the middle fossa into the posterior fossa, and that's the tumor in the ambient system and from the crural system. And then you can actually go to the CP angle right till the 7th-8th complex. And then you can remove the tumor from the 7th-8th complex there. You can actually see the tumor going to the opposite side. And then we go anterior to the third nerve, and you can put an endoscope and see it going, and you can go across. This was another case we operated with this approach, bilateral approach. This was Rosai-Doffman, bilateral histiocytosis. Use this approach. I'm a good friend of Ohata, and I believe that giant craniopharyngiomas, a lot of posterior extension should be operated with a posterior approach. So I use not the Hakuba's approach, but I use the anterior transpetrous approach in this, especially with the posterior fossa extension. To conclude, transcavernous anterior transpetrous rhomboid approach can give you a very wide spectrum with extradural lesions for like chordomas, chondrosarcomas, angiofibromas. Interdural, like a dumbbell-shaped schwannomas, like you said. Intradural, Petroclival meningiomas and basilar aneurysms. Most important is mastering the anatomy. The cadaver anatomy is very important. Mastering the magnification. A modern skull-based surgeon has to be a master of both microscope and endoscope. And here we introduce our training lab, and we have this for the last 40 years. I've been taking care for the last 20 years with both endoscopes and microscope with 3D. And we don't believe in workshops now. We believe that if you want to train a microvascular anastomos, it has to be a 2-week or a 4-week or an 8-week program. Train more than 2,000 neurosurgeons from 24 countries. Probably the cheapest lab in the world, because the trainees becomes a research subjects actually. And we've been active in the COVID era. And this is what we actually do. This is New Delhi, Northern India. This is AIMS New Delhi. These are my teachers who started the lab 40 years, maybe more than 40 years ago. It has multiple Indo-German, Indo-Japanese collaboration. And we believe that if you want to become a skull-based surgeon, you have to master the anatomy. You have to be there. And microvascular anastomosis on celastic sheets. And then the final is once they've done, and all this is actually scored by our technology experts. This is put in a server, and with computer vision and deep learning algorithms, they're making the scores, then how the surgeon can be scored. There's a lot of research going in this area. That's my friend Martin. So it is a lot of evaluation works which are happening, but still I believe that whatever I say can be redundant after some years. Thank you very much.
So thank you, Ashish, for a wonderful presentation. Now we go on to my very good friend, Jim. Jim and me, we go back a decade right now. I think we met for the first time in 2012 when we were teaching together in St. Louis. And I think it's, can't believe it's 10 years, time just flies. So I would invite him to talk on the transcavernous corridor. And it's an honor to have you here, Jim.
Great. Thank you, Aip. Thank you for this very kind invitation, and congratulations for putting this spectacular webinar together. Can you see my screen?
Yes.
Yes, we can.
Okay, terrific. Well, I think the prior speakers have done a fabulous job in really outlining the surgical anatomy and concepts to the cavernous sinus, and I will hopefully in the next half hour continue to build upon those surgical concepts and principles and give you sort of my philosophy and strategies in approaching the cavernous sinus, and really some applications on how to use it to your advantage in dealing with various skull base and vascular lesions. The cavernous sinus, it's often labeled as no man's land, and Dwight Parkinson beautifully described it as the anatomical jewel box, and as you know, it contains a lot of important structures, namely the cranial nerves and carotid artery. Professor Dolence has really taught us the various surgical avenues to get to the cavernous sinus, and also working in and around lesions of the cavernous sinus. And we must not forget the teachings of Professor Roten, who really taught us not only the anatomy, but also having that concept of having X-ray vision in being able to see the anatomy behind hidden layers of tissue and hidden layers of pathological tumors and lesions. The workhorse for the anterolateral lesions really is the orbitozygomatic approach, and I've tailored my approach over the years to make it only a orbitopterional or modified OZ, and this really gets you to a lot of the lesions in this area. I no longer use the zygomatic component, as many have shown through anatomical studies that it doesn't really buy much, especially when you're working in mostly this anterolateral corridor to the cavernous sinus and suprasellar region. This is an example showing the standard incision I use, and I always harvest a large vascularized pericranial flap, as this is very important when you're reconstructing, especially if you're resecting the lateral wall of the cavernous sinus. And this is the typical exposure extradurally that you would see. You could see the superior orbital fissure and optic nerve canal have been decompressed. And really the key in unlocking the cavernous sinus, as I beautifully demonstrated earlier, is the meningoorbital band. And this is the gateway to unlocking that cavernous sinus and really using the applications of this pericavernous technique. So when you cut the meningorbital band, you unlock it by peeling the dura away from the lateral wall of the cavernous sinus. The temporal lobe dura is the dura propria, and you can separate those two layers and expose the superior orbital fissure, but also prepare yourself to decompress the optic nerve extradurally and to resect the anteroclinoid process extradurally as well. And there's a variety of benefits of using this technique. And I'll show you several examples in tumors and vascular lesions, but really it's to have this early control of the optic nerve and carotid artery, and to perform early decompression of the optic nerve, especially for compressive lesions, as this frees the optic nerve from pressure so that you minimize any injury to the optic nerve during surgery. When you're peeling the dura, it should peel off like an orange. It should separate nice and easy. If it doesn't separate easily, you have to reinvestigate that you're in the proper plane. You could be in the wrong plane if you're meeting a lot of resistance. As you know, the anatomy of the cavernous sinus has two layers: an outer layer made of the dura propria, which is the temporal lobe dura, and the inner periosteal layer that covers the Gasserian ganglion and the cranial nerves. And the three approaches when we unlock the cavernous sinus is you can do the Hakuba technique, which is doing it from anterior to posterior, front to back, namely peeling the dura propria off of the superior orbital fissure, V1, V2, and V3. And I generally use this mostly for resecting the anterior clinoid process and decompressing the optic nerve. The peeling of back to front is the Kawase's approach that Ashish beautifully showed. And then the Dolenz approach is really cutting the tentorium, decompressing the optic nerve, making that superior cut for decompressing the third nerve and cavernous sinus meningiomas, which I'll show you later in this video. So when we decompress the optic nerve extradurally, this is a very useful technique when you're dealing with meningiomas in the medial sphenoid wing region, as often these tumors can invade the cavernous sinus and extend into the optic canal. This is the intradural variant, come from Mike Lawton's textbook, where you open the dura over the clinoid intradurally and perform the same maneuvers of decompressing the optic nerve and taking off the clinoid. I've since adopted a hybrid technique where I do the majority of the extradural work, and namely because I like using a spinning drill as opposed to a ultrasonic aspirator. I just think it has better tactile feel. But with the spinning instrument, that can be risky to intradural structures, so I prefer to do pretty much 95% of this extradurally. And you see this last tip at the very end. This tip is usually very difficult to get to extradurally, especially if it's prominent or long, or if it's even fused to the middle clinoid in some cases, in which case I will do the rest of it intradurally using a hybrid clinoidectomy technique. And when you resect the clinoid, remember that the base of it is the clinoidal segment of the carotid artery. And you should get this view after you open the dura to be intradural and extradural to get this view. And the advantage of having this exposure is that if you have a large pathological lesion like a meningioma that's encasing the carotid artery, you have identification of the normal anatomy extradurally, which is the optic nerve and the carotid artery, so that when you have this exposure, you know where to find the optic nerve, especially when it's severely displaced, so that at the end you get this beautiful view of the optic nerve, carotid, and the third nerve. And you can see we've resected the lateral wall of the cavernous sinus in this case, which was a meningioma, and you can see all the nerves and the arteries are nicely decompressed. So here's an example of a sphenocavernous meningioma. You can see the tumor is large, and it's arising from the lateral wall of the cavernous sinus There may be even some microscopic invasion of the cavernous sinus as well, but it's causing significant mass effect, T2 edema, which signifies some peel invasion. And it's important to study the vasculature, so I typically will get a CT angiogram to look at the bony anatomy, but also the vascular anatomy. And you can see that the PCOM is displaced medially here at the P1 PCOM junction. And also you look for any hyperostosis here. Now, the traditional approach that probably most people in the community do is the purely intradural approach, where you open the dura and you try to resect the tumor from inside to out. And if you do that, you generally will leave the dural attachment intact. But if you do an extradural approach, where you do the peeling technique and you separate the extracavernous from the intracavernous, you can resect this dural attachment and achieve theoretically a Simpson 1 or close to a Simpson 1 resection by resecting the lateral wall of the cavernous sinus. And this is the skull base approach to these lesions. And so when we do this, we unlock the cavernous sinus, we can peel the lateral wall to expose V1 to V3, and then we resect the lateral wall of the cavernous sinus. And this technique allows you to separate the extracavernous from intracavernous tumor using this orbitozygomatic modified one-piece approach. So we've taken the exposure up to this point, and so we'll now begin to unlock the cavernous sinus by cutting the meningo-orbital band and then using a sharp, heavy skull-base dissector to start the peeling procedure from the dura propria and exposing the area where we can now start to drill the anteroclinoid process. And we're doing this through an eggshelling technique using a high-speed diamond drill with lots of copious irrigation. And so remember that the optic nerve and the superior orbital fissure now are roughly about 15 degrees separated at an angle. So now we open the dura and open the sylvian fissure widely, exposing the MCA. Once you have the MCA exposed, it's now safer to start debulking the tumor, keeping in mind that the MCA and carotid are on the medial side of the tumor. We then separate the tumor from the temporal lobe, and then we can cut the dura into the orbital apex towards the optic nerve, and we can decompress the optic nerve by incising the falciform ligament and the optic dural sheath. And this step is very important because this will give you early decompression of the optic nerve, and then we can continue that cut laterally across the optic nerve, across the cuff just above the carotid artery, which is the distal dural ring, and then continue the cut across the roof of the cavernous sinus. And now you're starting to see the PCOM proximally here, and we'll continue the cut using the Dolenz technique, incising the dura across the roof of the cavernous sinus. And this allows us to detach the lateral wall. So now we've resected the dural attachment, and now we're left with the intradural component of the tumor. The tumor is quite large, so I generally recommend more debulking. It's tempting to try to roll the tumor as one piece, but please resist that temptation because there are small vascular perforators coming off of the MCA on the medial side. Remember, there's also a choroidal artery on the medial side. If you don't isolate and protect the choroidal artery, you'll have a post-op hemiparesis if you injure the choroidal artery. So remember, resist the temptation to want to roll out a big piece of tumor and that temptation to want to flex your muscles. Remember, continue to debulk, make the tumor smaller so it's more manageable, and being careful of those booby traps of those vascular perforators. And once you've done that, you can now release the tumor and visualize the posterior fossa anatomy, where you can see the SCA vessels, tentorial edge, and here's the third nerve going in to the oculomotor trigone. And again, you can get this nice postoperative resection and an intact patient if you avoid those vascular injuries. Here's another sphenocavernous meningioma. What's unique about this case is look at the flow voids. When you see all these flow voids here, be cautious, because when you do the angiogram, you'll see that the vascular feeders are not coming just extradural, but also from the intradural, intracranial cavernous ICA. And these feeders cannot be safely embolized because they're coming from intracranial circulation. So you really need to use that peeling technique where you can peel the tumor, get early devascularization so that the tumor is no longer fed by the cavernous ICA, and resect the lateral wall to get a Simpson grade 1 resection. Now, how about this large sphenocavernos meningioma? This patient was having progressive visual loss, but look at the vascular encasement here. The ICA is completely encased, and you have a very hyperostotic anterior clinoid process with mass effect, midline shift. So this is where having that hybrid extradural, intradural exposure is really important, because all of this anatomy intradurally is displaced. You have no idea where the carotid is, where the optic nerve is. You don't know if it's encasing any of these structures. So sometimes it's important to be able to have this proximal control so you can work from normal anatomy to abnormal anatomy. Here's the video demonstrating this technique. Again, we will peel the lateral wall and extract the anterior clinoid process extradurally. We open up the dura and perform wide splitting of the sylvian fissure, and we now expose the carotid artery. And luckily here there's a nice arachnoid plane separating the carotid artery from the tumor. And so now, once you know where the carotid artery is, you can start to safely debulk, but be careful how deep you debulk. Notice how I'm lifting the tumor away from the carotid artery as I'm debulking, so I always have the artery in sight. And then I separate the tumor by incising the tumor directly off of the carotid artery and following that arachnoid plane towards the proximal ICA. I can now open up the dura over the orbital roof, communicating it, giving me that combined extra and intradural exposure, incising the falciform ligament. And I'm sorry my lecture is so boring, it's putting someone to sleep. But we now further debulk the tumor and excising the temporal component. And I like to break up the tumor into various components with the lateral component. This is the tumor that's being excised off of the lateral wall of the cavernous sinus. And there's the intracavernous component. We finish the peeling, continue the peeling off the lateral wall, and then incising the roof, completing this Dolence technique of excising that lateral wall. And now we're left with the intradural component of the tumor. Here's the component of the tumor that is extending over the tentorium into the posterior fossa. We release the CSF from the prepontine cistern, getting more brain relaxation. And again, continuing to safely debulk instead of resisting, instead of falling into that temptation of wanting to yank the tumor out before having identified all of the vasculature on the medial side. So here we've identified some of the choroidal and PCOM takeoffs. Here is the brainstem. Here is the SCA vessel. You can see a lot of arachnoid adhesions to the medial side of this tumor. And staying on that tumor arachnoid plane, separating it from the important vasculature. We still haven't identified the third nerve yet, which is concerning. Again, large tumors like this is largely displaced. So after we've removed the lateral component, we can now safely move to the medial component and expose the tumor off of A1. This is the recurrent artery of Hübner. And now we find the optic nerve. Here's the optic nerve that's been displaced and flattened inferiorly and medially. You can see here's the optic nerve. It barely looks like an optic nerve. It's very flattened. And then the last portion of the tumor is this portion just lateral to the proximal ICA. And there's the third nerve. We see the third nerve now coming into view. It's strangulated by some tumor, so we'll incise the oculomotor foramen and then deliver the tumor into the suction vacuum here to get this removal. And the last component is this intracavernous component, which I generally use for radiotherapy. So now we rotate our large vascularized pericranial flap for reconstruction to prevent CSF leakage. And here's the post-op scan. You can see we achieved our goal of decompressing the extracavernous, leaving this intracavernous component for radiotherapy. And this is my approach for these meningiomas that invade the cavernous sinus. I generally don't chase the tumor into the cavernous sinus unless it's soft and suckable, mostly to preserve cranial nerve function. We can also use the peeling technique when we're dealing with extradural tumors like this giant juvenile angiofibroma. For a tumor like this, we've published our philosophy and technique and strategy on doing this through a multi-corridor approach. So the idea here is we're going to come from above with an OZ pericavernous approach, and the strategy here is to separate the tumor from the cavernous ICA, so that when you come from below with an endoscopic and Caldwell-Luck approach, you have more confidence to remove the tumor, knowing that the cavernous ICA is now protected. So here we are demonstrating that Hakuba technique, where we unlock the cavernous sinus by cutting the meningorbital band, peeling the dura propria off of V1, V2, V3, and then skeletonizing the foramen ovale and rotundum, and we'll open the periosteum in the anteromedial triangle between V1 and V2. We identify the tumor, and we start to peel the tumor away from the cavernous sinus. And the idea here is that we're trying to not remove the tumor through these corridors, but rather we're using this corridor to separate the tumor from the ICA, so that now when we come in from below, we have confidence that the ICA is protected, and that we'll have more confidence to debulk and remove the tumor without that risk of injuring the ICA, which is going to be the last thing you see on these tumor removals from below. And we remove the tumor from below through these two corridors because you have a wide access, beautiful visualization endoscopically through the nasal cavity, but also through the maxillary sinus corridor through the Caldwell-Luck maxillotomy. So here's the tumor being dissected from the infratemporal fossa. We preserve the main trunk of V2, and now we dissect the tumor from the infratemporal fossa away from V3 and delivering it from the hard palate, which it has eroded through inferiorly, finding those last vascular feeders, and then now we can deliver the tumor from this Caldwell-Luck maxillotomy. So we have the advantage of working through several corridors. There's the temporal lobe dura, there's the skull base resection cavity, and this patient had a beautiful resection, neurologically intact with very minimal V2 numbness, which is often seen in resection of these tumors. This is another example of using a combined approach. You can see the intradural component here was used and controlled with the modified OZ approach. And we did this through 4 stages, namely because this tumor was primarily fed by cavernous ICA. And these are very treacherous because you cannot embolize the cavernous ICA due to the risk of stroke. So you end up having a very vascular, hypervascular surgery with lots of bleeding. And you have to be careful, especially with pediatric patients, of knowing when to stop and to come back and fight another day. And so we were able to fight through this through multiple staged approaches and finally get this type of result where we got a gross total removal of this very treacherous JNA and bring this patient to safety. So he's done quite well and recurrence free. Intradural clinoidectomy for vascular lesions. This is an excellent technique when we're dealing with carotid ophthalmic artery aneurysms. And in this diagram from Hunt-Bajer, you can see that the clip application is using the traditional side curved clamp. And the advantage of using a side curved clamp is that you can bring the blades of the clip parallel to the axis of the ICA. So here's a demonstration of a smaller carotid ophthalmic aneurysm. We've open up the falciform ligament to decompress the optic nerve. But it really gets you this exposure, and the clinoidectomy is very critical because it makes more room for the shank of the clip, so that when you rotate your hand so that the clip blades are parallel to the axis of ICA, the shank of that clip has room where that bone used to be. So multiple functions for the anteroclinoidectomy. Here's the ICG showing reconstruction of the ICA. What about for much larger lesions? This is a giant paraclinoid superior hypophyseal aneurysm. It presented with a subarachnoid hemorrhage. Sugita nicely taught us the fenestrated clip techniques to reconstruct the lumen of the ICA, and Bajer and Sampson taught us the suction decompression retrograde technique, where we suction decompress and deflate the aneurysm so we can start to reconstruct the lumen of the ICA with less risk of intra-op rupture. And that was done through a decompression through the neck. Here I'm demonstrating a technique where you can do direct decompression if you have good exposure of the proximal ICA after your clinoidectomy. So we've done the clinoidectomy, and now we go intradural and decompress the falciform ligament, where you can see the optic nerve is strangulated by that brown discoloration. We then open up the dura towards the orbital apex, and you have to create the distal ring. The distal ring is not a potential space between the dura and the artery. It's in fact adherent to the adventitia of the artery, but you create a cuff by cutting a dural ring of dural cuff around the ICA in a 270-degree fashion. But look at how I have proximal control now of the proximal ICA. I have distal control as well on the distal ICA. And so now, instead of doing the traditional Dallas technique where you open the neck, I can then trap it by putting a temporary clip on the proximal ICA, a temporary clip on the distal ICA, and now I can do direct suction decompression with this butterfly needle, and then decompress and deflate the aneurysm. And what I'm looking for here is the choroidal artery. I'm looking for that choroidal artery, and we'll start to reconstruct with fenestrated clips. But look how the calcium in the neck here is causing the clip blade to slip down and kink the lumen of the ICA. This becomes problematic. So how can we reconstruct this lumen with this big piece of calcium here? So what I typically do is I try to close off all the soft parts of the aneurysm, being careful not to tear the dome with that calcium. So we're going to use a combination of right angle fenestrated with straight fenestrated clips. And then at the end, we'll close off this dog ear using this gentle curved clip. And then here is the choroidal artery. We find the choroidal artery, separate it, making sure that that choroidal artery is out of harm's way before applying the next clip. And so we'll come in from behind this right angle clip and make sure we gather the remnant of that neck so that we fully close off the aneurysm while preserving choroidal artery. And then we'll reinforce our clips with some vertical fenestrated clips. And then here's the final view. You can see the lumen is now nicely recreated. Look at the speck of calcium that's here. This portion we have to leave behind. And then we'll shoot an IC green. You can see a nice filling of both ICA, M1A1, and the choroidal artery that you can see here in the depths. And here's the intraoperative view. Here's the postoperative angiogram showing nice reconstruction of the ICA. Here's a recent case I did. This was another superior hypophyseal aneurysm, and this presented as a suprasellar mass. I don't have the MRI here, but I can tell you it looked like a pituitary adenoma, and you have to be very careful and recognize that this is a partially thrombosed suprasellar aneurysm. You could see she's losing vision dramatically in the right eye and with bitemporal hemianopsia. And with this approach, of taking off the clinoid and even opening up the oculomotor trigone, we were able to reconstruct this and decompress the optic nerve. And here's the postoperative angiogram. Here's an example of a giant carotid ophthalmic artery aneurysm, again presenting with visual loss. In the case of visual loss, my preference is to do surgical decompression as opposed to flow diverting strategy here. And for this one, I'm demonstrating the Dallas technique using the modified OZ with a neck exposure. And here we're going to isolate the carotid bifurcation in the neck, do the OZ from above, and then we'll go ahead and do the Hakuba technique in unlocking the cavernous sinus, exposing the superorbital fissure. Here we're cutting the dura along the temporal side of the clinoid, and this allows us to meet with the exposure of the V1 area of the superorbital fissure, and we can continue to peel that dura propria extradurally so we can do our extradural clinoidectomy. I debulk a little bit of the clinoid first before going towards the optic nerve canal, and then we start to decompress the optic nerve canal here. Then we'll go ahead and incise the falciform ligament. Here's the falciform ligament. Notice how the optic nerve is quietly spread. And then we'll go ahead and incise the distal dural ring. Here the dural ring is flapping into the exposure, so I'm just suturing it, and this helps tamponade a piece of gel foam that's holding and controlling the cavernous bleeding from the clinoidectomy defect. We'll now go ahead and trap the aneurysm by putting a temporary clip on the external and then a Fogarty clamp on the common. And now we'll put a distal clip here on the distal ICA, and we'll put a butterfly needle in the common carotid artery, and I prefer to put it in the common instead of the internal because there's less risk of dissecting the internal carotid artery. We'll then go ahead and aspirate, and look how this aneurysm just deflates. And now you can visualize ophthalmic artery takeoff. We're identifying the proximal neck of the aneurysm, and we're going to identify the distal neck of the aneurysm and go ahead and apply the side curved clip initially. Visualizing the ophthalmic artery, making sure it doesn't get kinked, making sure the clip blades are not compressing the optic nerve. And then we'll take the butterfly needle out and reconstruct or suture the puncture site. And so here's the post-op angiogram demonstrating a nice reconstruction of the ICA. And then lastly, I'll show this example. Here's a combined ICA with basilar apex aneurysm. This is a ventral paraclinoid aneurysm with the basilar, and my endovascular colleagues felt this would be a difficult basilar to coil, and so the idea here is to clip the basilar but get the ICA on the way in. So let me just jump to the video here due to the interest of time. We're going to do our intradural dissection. We've done our clinoidectomy, and here's the ICA aneurysm. We're decompressing it from the third nerve. And you can see it's not a straightforward PCOM aneurysm that can be easily be mistaken. It's got this fusiform appearance, so we're going to reconstruct it using a series of fenestrated clips, and then we're going to stack them together to reconstruct this lumen. And after we've reconstructed it, we'll then turn our attention and open up the arachnoid in the carotid oculomotor trigone. You can see there's some PCOM perforators in the way. You can divide them and separate them, but here I'm going to work around them. I just prefer not to take any perforators if I can avoid it. And there's the basilar apex. There's the distal P1 basilar junction. And we're going to use a tandem clip technique to clip this aneurysm. And with that, we use a fenestrated clip first, focusing the distal blades on that distal P1 basilar junction to reconstruct that neck. And by doing that, we can then sneak in from behind with that fenestration with a gentle curved clip and grab this backside of the remnant of the basilar and then close off the remnant on the backside there. And so here's the operative view, 2-for-1 approach and post-op angiogram. So I think due to the interest of time, I'll stop there. I do want to just say one thing, that when we're doing clinoidectomy, you have to use it judiciously and tailor your clinoidectomy to the patient. I no longer take off all pieces of the clinoid if you don't have to, because you can have injury. This is a carotid injury I'm showing you here. As I'm drilling the optic strut, my mistake here is I wasn't paying attention to the distal side of the drill bit. It's very easy to focus on one surface and be tunnel vision and forget that there's another surface to the drill, but you can see there's a weakening in the clinoidal segment of the ICA. And before I know it, I was encountering this brisk arterial bleeding. And, this is problematic, obviously, but we were able to fix this problem with a muscle graft. And you can take the muscle from the temporalis, because it's right there. You crush it with a clamp to release the clotting factors and apply pressure to this area by putting the muscle graft there and then holding pressure. And I held pressure here for about a good 45 minutes with lots of cottonoids, and I got the bleeding stopped, and I was able to take out the tumor and finish the case and then go down to angiogram. And luckily there was no pseudoaneurysm on early or delayed angiograms, and she was able to get a nice result. So I'll conclude here. Thank you, Ipe, again for this wonderful opportunity, and congratulations on this terrific webinar.
Excellent, Jim. Very good. I would now ask Luis. Luis is the next presentation. Luis, are you around?
I haven't seen Lewis. Jorge's here. I don't know if you want him next. I don't see Lewis.
Yeah, I mean, Luis had told me that he would be here, but then what happened to him is he had a case. So he told me that he probably will present last. So Tetsuro, I haven't seen him here because Tetsuro has a case tomorrow morning. So if Yohei is here, maybe Yohei can go ahead and present. And if Luis can finish his case within that time, fantastic. Otherwise, we'll call it a day.
Jorge,
thank you very much.
Okay.
Yes, I'm here.
Let
I'm
me
going to
first introduce Yohei to the crowd,
okay.
please. Right. So again, I know Yohei for the last 10 years. We met in St. Louis. So he is he's gone ahead and described this MIPLATA, where he's doing a minimally invasive approach to Petroclivals, which is unbelievable. So, but then I have seen it a couple of times. We have hosted him on Ignite channel quite a few times, and I've seen his videos. They are remarkable. So this is obviously the future. The future is learning anatomy and then going less invasive safely. So that is what Yohei will be showing us. Thank you very much for joining us, Yohei.
Thanks to you. And I'm going to share the screen. You see my screen? Yes?
Yes, yes, yes.
Okay. Well, today we will talk about the very similar to Michael Lawton and James and the professor in the show. I'm not going to show you nothing new. I only want to show you a way to do the same things for a little less invasive philosophy, because we must, as we talk all the time that we are together, there are a lot of techniques that show or said that are as good as surgery, but less invasive. That the real thing is, like James just showed, For example, in vascular pathology, the clipping eliminate the aneurysm, and in tumor pathology, we can eliminate the tumor or make much more effective the radiosurgery, for example. This is my conflict of interest. The first thing I want to be very thankful to my master professor, Evandro de Oliveira. I was with him in 1998. And just a few months ago, we can finally publish the Mi Plata concept. There is a minimally invasive concept using the cavernous sinus to get to the posterior fossa, or a way to take out the tumor. This is not my philosophy. For example, Ari Krish always talk about this. And this is my former fellow, Rafa Martinez Perez, who work in the United States. And the concept of Mi Plata is using the cavernous sinus and the extradural corridor in order to gain space. Why? Because we don't want to use a space outside in the patient. We want to use a space inside in the patient. It's the same that, for example, when you do a transnasal approach, the craniotomy of the transnasal approach is in the sella turcica, for example. It's not in the nostril. It's inside the patient. This is the same concept that we must apply in the skull base. Our craniotomy must not. We must forget to think about our craniotomy outside, perional, orbitozygomatic. We must think that our surgery is inside. It's in the cavernous sinus. There is our craniotomy, because there is the way we're going to open to get to the posterior fossa. I'm not going to show you today, for example, the paraclinoid. For the paraclinoid, is even simpler, the craniotomy, because you can do a mini-pterional. And because the main thing that you need for clipping the aneurysm is take out the clinoid, is release the carotid ring and use the a small portion of the middle fossa peeling in order to expose B1 and B2. You got enough space and you can clip any paraclinoid aneurysm. Even you can do a bypass. For example, one colleague of mine 6 months ago, he ruptured the carotid in a transsphenoidal procedure, and the endovascular occlude the carotid artery using coils from the petrous to the clinoid segment of the carotid, a lot of coils. But the patient got ischemia of the brain. And then I said, okay, we're going to do a bypass, but I don't want the patient got any ischemia, because the patient only have anterior communicating, not a good posterior communicating, and got irrigation from the ophthalmic. And then what I did, I exposed the clinoid segment. I take out the coils and I put my bypass there, because I don't want to put any other ischemia that the patient already have because of the coiling. And after that, I went to the neck and I do the high flow. Then it's very important that we know the anatomy. And as Michael Lawton said, we need to tailor the approach. We must not now in modern philosophy, we must leave the concept of do all the surgery for the patient. This is only to show you the Mi Plata concept that came from the sphenopetroclival meningiomas, and we don't have time for this, but I don't know if I can. This kind of tumor, this is a small tumor, you see, but it's a sphenopetroclival, and then what you need in this kind of tumor, you don't need to go inside the cavernous sinus, but you must release the nerves. That's the concept of Mi Plata, release the nerves. I don't want to take the exophytic portion of the tumor. I want to release the nerve as well, using the extradural corridor in order to avoid to use a big opening in the outside. Why? Because for the postoperative recovery of the patient is much more easy when the patient have less invasion outside. And for example, you can see in these cases a mini-pterional. You don't need a complete pterional. In why is in skull base is so important the mini-pterional, or mini, in this case is a mini pretemporal. It's not mini-pterional, but it's the same concept. When you use the mini-pterional or mini pretemporal, the concept is the superior temporal line. Why? Because if you use the superior temporal line as your upper limit, you avoid to open the frontal sinus. And in a skull base, the most important complication is CSF leak. And any attempt that we can do for avoid CSF leak is very important. If you see here the difference with all the people that present before me, I never open the dura because I want the dura covering the brain. I don't want to see the brain. I don't need to see the brain. I need to see the vessels. I need to see the nerves. And in this case, we open the ligament, the falciform ligament from the outside, and the same thing with the carotid. And we leave the dura. Why? Because that dura is part of the tumor, and you need to take out with the tumor. You're not going to leave the dura because it's a remnant of the tumor. Okay. And then what we have here is we are using the extradural corridor. We release the optic nerve. We are going to release the carotid. It's the same concept that James showed you, but the difference is I always keep the dura over the brain because I want to release the nerves. This, for example, this patient was a pilot, airplane pilot, and the patient got a problem with the third nerve. For a pilot, it's very important. And then what we did is release of the third nerve. If you only take out the tumor and you don't release the nerves, the patient keep with the cranial deficit. You need to use radiosurgery. You're going to spend 1-2 years waiting for eventual recovery. But in this case, you can achieve that. We have this published and the results are very good. But you must do the surgery thinking about the releasing of the nerves. Which nerves can be released? Of course, the third is the optic, the fifth nerve. The fourth nerve is very difficult. It's very, very difficult. In this case, because the patient was a pilot, I did that, but it's very difficult. You can cut it. If in this case I cut the nerve, it will be terrible for the patient. Fortunately, we can preserve the nerve. And the other thing that nobody say in any presentation is the fourth nerve in the cisternal portion is 2 times the intracavernous portion. Why? Because the tumor compressed the nerve. It's very important you think about that. If you want to find the same size of nerve into the cavernous sinus, you never find it. You always cut it. And then it's very important. And the reconstruction, the same thing that James said, came from your flap. We have temporal fascia, temporal fat, and we can leave a portion of the tumor that you can use radiosurgery, but you release the third. For me, the releasing of the third nerve is very, very important in this kind of surgery. But everything came from the microsurgery and the anatomy. And you must learn the both. It's impossible to do this kind of surgery if you don't have the microsurgery and the neuroanatomy. I was very lucky because when I was in Brazil, I spent my year with Wen Hung Su, who is one of the best fellows from Dr. Rotten, and Elder Tedeschi, a very good neurosurgeon who teach me a lot about microsurgery. I was very lucky as well because in 1998, I met Professor Akira Hakuba. And Akira Hakuba in 1982, he described the anterior petrosectomy. Even if his technique is a little bit different of Kawase technique, the first one who take out the anterior petrous bone was Hakuba. The first one who take extradural anterior canalectomy were Hakuba. And the first one who described completely the lateral wall of the cavernous sinus was Hakuba. And then it's very important to know that for me it's a very good what I heard from James, that we must recognize Hakuba of one of the father of the paracillar region, because a lot of people talk about Dolenz, but Dolenz described the anterior canalectomy for aneurysms in 1985 and for this cavernous sinus in 1983, and Hakuba described this 1 year before, 3 years before than Kawase, the anterior petrosectomy. And then it's very important to know about the history. And it's interesting when we talk about the anterior canalectomy, which is the main maneuver that we use. All the people who talked before me, you can see that the anterior canalectomy is the key of all of this region. And then if we think about the first one who took out the clinoid for subdural root was Drake in 1968. He named the carotid ophthalmic aneurysms, the superior ones. And then the Dolenz and Hakuba, the European and Japanese, described the extradural, and Dolenz the combined root. This is a figure from 1999 of a paper in the Acta Neurochirurgica from Dolenz. And we can think the history, why the Americans love a lot the subdural one, and why the Europeans and Japanese do use the extradural or the combined. But we can see today, Michael Lawton, James Liu, the professor from India, and me, everybody use now the extradural, the subdural, and mainly the combined route. You see, because the things always came together when they work. And it's very important to know the cavernous sinus anatomy. And when the people study, they don't think about the names. For example, the clinoidal triangle of Dolenz triangle, the oculomotor triangle, Hakuba triangle, the supratrochlear triangle, the infratrochlear triangle, or well known as Parkinson, that you can in that triangle get the carotid artery and the sixth nerve. And this is very important when you use the cavernous sinus in a normal cavernous sinus as a highway to the posterior fossa, because you need to occlude the cavernous sinus venous bleeding. And it's very important, and nobody talk a lot about that, but it's very important. Today, for example, Michael Lawton showed a very important video, 2 videos. He said, when you take out the clinoid, you open a hole in back of in between the third nerve and the carotid artery. You know, when you make a hole there, you open the cavernous sinus, you have the bleeding in that hole, you put your fibrin glue, and then you can tamponate all the superior portion of the cavernous sinus. What I do is the next step in between B1 and B2, I put the fibrin glue again. And in the last one I use fibrin glue is in the Parkinson triangle. That is very big. And I recommend first to put a little amount of Surgicel in the superior petrosal sinus. If you put in the superior petrosal sinus Surgicel and fibrin glue, you have isolate the Parkinson triangle, only the connection to the basilar plexus. And then you put the fibrin glue, and you have a complete occlusion of the cavernous sinus, not all the cavernous sinus, just the portion to the outside. And then you can control, and you can release the nerve without the risk of coagulate. And then the paraclinoid is always I think when the people start to operate cavernous sinus, they must start with paraclinoid because it's the most simple one to treat. And the second thing is the clinoidal meningiomas, because in the clinoidal meningiomas, just taking out the clinoid and release the optic nerve and the carotid artery, you are done. You only need to do a mini peeling. And after that, you go for the next, the Petroclival meningiomas, lateral wall cavernous sinus meningiomas, paraclinoid or Petroclival meningiomas, and whatever, But to start, it's much better to start with the simple things. And then we have a huge experience in paraclinoid. And then when I started from 1999 to 2014, I used the Dolenz approach or Hakuba approach. You can name any one of you want. What is that? Is using anterional. You can use a Hakuba approach as well. The fronto-orbitozygomatic approach was well described for Hakuba as well. And but we changed in 2015. We start to use mini-terional, and after that, mini-pretemporal. We don't use orbitozygomatic approach since 2008. We don't take the orbital rim in any patient of any pathology for 13 years or 14 years. Why? Because this is of course controversial, but I think you don't need that. But yeah, as you've seen before, everybody used the orbitozygomatic, and then we need to respect the philosophy of everyone. But what I can tell you, if you use lumbar drain, if you use extradural corridor, you don't need to take out the orbital rim in a pathology. But if you are more comfortable with that, you must use that. And the other thing is use the endoscopic concept that I learned from the Japanese, the suction irrigation, but in microsurgery, not in endoscopy. And then I use that since 2015 and changed completely my surgery, because I can focus better for example, the bipolar, and I can keep all the time a clean feel in my surgery. And the other thing is the Kamiyama scissor. The Kamiyama scissor, this shape semilunar lateral side scissor is magical in order to release the nerves from the cavernous sinus. Why? Because when you use the classical scissor straight,
the picture is frozen.
If you go from the extradural to the subdural, you hit the nerves, and then you produce damage. But when you use this kind of side semilunar, semi-curved scissor, you don't hit the nerves, and then you can release from the inside the cavernous sinus the subdural portion. It's not possible with other thing. It's the same that happens when you clip, as James Liu showed, the 747 clip, that is the number of the lateral side curved clip, is the best clip for paraclinoid superior oriented aneurysm, because follow the direction of the carotid. This is the same for the nerve.
Excuse me, I'm sorry, Jorge. Jorge, the screen is not moving. I just noticed.
Really?
Yeah.
Then now?
Yeah, it's, yeah. Yes,
Let
Tashiki Hospital.
me see. Let me see.
Tashiki Hospital.
Now?
Yes.
It's okay? Okay. And then this, since 2015, I showed you that I use the mini Hakuba and the micro Hakuba, the keyhole. And the other thing is the suction irrigation and the Kamiyama scissor. And then you can change. I started to use the supraorbital from Yuha and Nesniemi first. But the problem with the supraorbital is you open the frontal sinus. And then I prefer to use the miniterional from Spätzler and the Figueiredo. And the other important thing is teaching. You must teach the young people because they give you the best ideas, always, the young people. And then I'm going to show you this less invasive philosophy came from Natal, 2005, Figueiredo, 2007. And very important that the mini-pterional approach is not just a small pterional. No. It's an anatomical concept. It's not a keyhole concept. It's an anatomical concept in order to avoid to open the frontal sinus. I take the picture with Professor Everval and Professor Natal in Cancun. And then the history of this is use the extradural corridor. The craniotomy is in the cavernous sinus for your surgery. And this is a new concept, a key exposure concept. Not a keyhole. Keyhole is just the size of the craniotomy. No, that's not important. Important is the exposure. The same thing happened, for example, in endoscopy. I repeat, the nostrils are always the same. But what do the people of endoscopy? They wide because they open the maxillar sinus, they open the sella, they extend up to the lateral sides. You see, it's the same philosophy we must use in our surgery. The craniotomy is not important in the outside because we have the brain and we cannot take out the brain like the anatomy. We need to focus our craniotomy like our craniotomy is in the cavernous sinus. I know there's no bone there. The bone is small. It's just the anterior clinoid, the anterior petrous bone, and the posterior clinoid. But it's a way to thinking. And then the exposure is minimal in the outside and maximal in the profound side. Okay, and the anatomy is very important. This is a session for my former fellow Tomás Poblete, who were fellow from Rotten. And look at this. This is a mini-pterional extradural approach, and we can take out the clinoid in a mini-pterional. This is the optic nerve. This is the clinoidal segment. This is V1. This is V2. We can see everything. You don't need to open wide the craniotomy because the focus of your surgery is in the bottom. It's not in the surface. It's different when we talk about IBM, glioma. Of course, you need to expose the brain as good as enough for taking the pathology. But here we need to go to the bottom, the posterior fossa, to the basal cister, to the skull base. That's the key exposure concept that I came with this word. I don't know if it's correct, but I think I need to change my mind. We can finally publish this a couple of years ago. We started describing the keyhole concept. The keyhole is this. It's very similar to the Paul Gardner transorbital approach to the skull base, but we use a small opening in the skin. We dissect the muscle, and we came taking out the anterior clinoid to decompress the optic nerve. This is good for tumors, for example, tuberculum cella meningiomas, when the carotid or the optic nerve are encased, because we use endoscopy for that kind of tumors since 2017. And for example, for a small paraclinoid, but you can go further there and you use the extradural mini-pterional, and then you can treat everything, paraclinoid, clinoidal meningiomas, and everything. Okay? And it's important to demonstrate this. And we have this paper with Prevedelo in order to quantify if it's good or it's not good to use mini-pterional. And it's good. It's comparable to pterional because I said to you again, forget about the exposure in the outside. And then we applied this, of course, in aneurysms and in tumors. And we came further with the concept, of course, of the extradural mini-pterional approach, because it's different to the mini-pterional subdural one. Okay, and this is the history of the approaches. And always remember the second weapons that are the things that you use in order to treat this. I must tell you that I never use drill in anterior clarinectomy. I only use drill when I have a very hyperostotic one in meningiomas, but most of the time I take with no drill, because I think that the damage of the optic nerves is for hitting, and that's why I'm not using the drill. Of course, I use the drill when I have a clinoidal meningioma and other things, but my philosophy is take out the clinoid without drill most of the time. And then it's just the typical is the petroclival meningioma. To understand this philosophy, for example, this huge tumor, now I have more than 100 of these cases. I can tell you this is a very hard one, because ossification of the tentorium, a middle portion in the middle fossa, in the sella turcica, a little bit in the cavernous sinus, and a posterior fossa. Is this possible to take out using a mini-pterional craniotomy? Of course, this is, look at this. This is no retractors. That thing that you see here is the superficial sylvian vein that is occluded because of the tumor. No retraction. The orbit is here, the zygoma is here, the muscle is here, because we are using the extradural corridor. And then we made the peeling of the middle fossa. This is V1, V2, V3, the fourth nerve, the third nerve that is released. And we use the cavernous sinus as our highway to take out this tumor. And I want, of course, to get to the posterior fossa as well. Okay? And look at this. I put a retractor because I want to take out the tentorium that is ossified, and was very hard. This is the Kawase triangle. Okay, this is the fifth nerve. This is the tumor in the posterior fossa. And then we take in everything. This is the brain stem. And we can take out. And the good thing about the middle fossa and this kind of philosophy is you release all the nerves. This is the optic, the carotid, the third, the PCA, the fourth, the fifth. And this is the portion into the cavernous sinus, but different, because we release the nerves in the entrance. Not only leave that portion to the radiosurgery, we release. The only nerve that we cannot release yet is the sixth nerve. The sixth nerve into the cavernous sinus is very hard to release, because I think that the Gruber ligament compress the sixth nerve, and then it's very difficult. And I always, for me, it's difficult as well, the care that you must take with the carotid artery. And inside the cavernous sinus is very difficult to identify in a meningioma. But and the reconstruction is very easy. We use the temporal fascia, and we go to the bone, and we occlude every possible hole in between B1 and B2, sphenoidal sino, optical strut, tegment tympani with fascia and fat. And then the brain gain all that space for the postoperative period, if you have brain swelling, for example. Nobody talk about that, but it's very important that you must think about it in the surgery. Look at this. This brain got a little bit of swelling, but no problem, because the brain occupied all this space. And you can see in the MRI, when you follow the patient 1 or 2 years after the surgery, apoptosis of the brain, because the space that we gain is bigger than the original half the patient, because we drill on the bone, you see? And then this is the postoperative period, the MRI, and this is the patient. I take the picture with care authorization, because this patient had operated 7 years ago. And this patient convinced me that we can change our mind and go for a less invasive kind of surgery in these patients. And then finally, the Mayplata concept is this: use the cavernous sinus, but in non-meningeal pathology. No meningeal pathology. The patient have nothing in the cavernous sinus. Mayplata concept, Rafa Martinez. And then this paper is from a couple of weeks ago from China that I saw in frontis in surgery. And they talk about the pretemporal transcavernous approach for non-meningeal tumors. And then, of course, it's using the cavernous sinus as a highway to posterior fossa. We must take in the side the trigeminal schwannomas, because the trigeminal schwannomas really they make a compression of the cavernous sinus, and the tumor, when it's huge, take out the petrous bone as well. And then you don't need to drill. You don't need to do nothing with the cavernous sinus. You only need to occlude the superior petrosal sinus. That's the only thing important in this tumor. And then for me, it's much easy to operate trigeminal, okay? But the rest of the tumors are difficult. And then the conclusions are very, very interesting. The first, the pretemporal approach, and that's why I named mini pretemporal, because my professor described the pretemporal approach in 1995. And the other thing is very important, the orbitozygomatic. Everybody use now not the frontal orbitozygomatic. They use the modified one, like James showed, that is much better. I don't use it, but I respect, of course, the people that use it. And the pretemporal transcavernous approach is very good for non-meningeal lesions. But the neuroanatomy, remember, never lie. If you go from the lateral side, the thing I said, not the roof of the cavernous sinus like Ali Krish, Evandro, Professor Dollens, I go from the lateral side. From the lateral side, if you take out the tentorium, you can see everything. Even you don't need to take out the petrous apex sometimes, or the posterior clinoid. If you go for the roof, you need to take all the bone. You need to split the sylvian fissure. You need more space because you need to drill for the subdural root. But if you take out just the tentorium, it's much easy, the surgery. But the problem are the cranial nerves. And then if you operate meningiomas, you know how to release the nerves. If you know how to release the nerves, you can do this kind of surgery. Because it's very, very interesting to see these anatomical dissections that Pablo Rubino, my friend, gave to me. But this is anatomy. When you try to do the same thing in the patients, you have deficit. And then it's very important not to coagulate. And you don't know how to control the venous bleeding. It's impossible to do the surgery. And then the venous bleeding, as I told you, you control with fibrin glue. Fibrin glue in the Dollens triangle, fibrin glue between B1 and B2, fibrin glue in Parkinson triangle, but you need to occlude before the superior petrosal sinus, because if you just put fibrin glue here, this is huge. You can have a migration of the fibrin glue to the jugular vein, very dangerous. And then you can occlude all the cavernous sinus without problem. Not all the cavernous sinus, sorry. This is a compartment. You just occlude the compartment you're going to open in order to use the cavernous sinus as your route to the posterior fossa. And this is not my idea, but nothing that I said to you today is my idea. All is a copy of other people. And then this is 2007, like in Shekhar and Ali Krish, they use this fibrin glue. And this is only to stress to you that this portion for me is very difficult, because I can occlude the superior petrosal sinus with Surgicel and fibrin glue. I can occlude all the rest of the cavernous sinus. I can avoid the CSF leak here in the sphenoidal sinus between B1 and B2. But here, my problem is the carotid artery and the sixth nerve. The releasing of the sixth nerve is very difficult. For example, for endoscopy, my colleague who do endoscopy, is easy for him to release the sixth nerve than for me. But for the surgery today, I'm thinking about the way to release the sixth nerve. Today, the radiosurgery is the answer, but not for all the patients, unfortunately. And then what I'm saying to you is applied for everything. For example, this very interesting paper of Ali Krish show about the PCOM. The people talk about the PCOM aneurysms, and sometimes you need to use the cavernous sinus, take out the clinoid, made a mini peeling in order to release the carotid to a perfect clipping of this kind of aneurysms. Some people said, why are you going to do this? Because sometimes you need it. That's why you need to be trained in this. And I comment this paper and I show that we the same surgery, but using a mini-pterional approach. And then the classical pretemporal is for the roof of the cavernous sinus. Dollens, Evandro, Ali Krish. You need subdural dissection. You need to take out the roof, anterior and posterior clinoidectomy. But when you use the mini-pterional concept, this is subdural, classical one. And you look at this. This is like the first floor that you're using. But if you got in for example, the second floor, but if you use the first floor, you use the extradural corridor. Look at this. We're using here, this line for the subdural one. But my subdural is here. And then I gain all of this for my extradural mini pretemporal root. And then I don't need to do a huge canotomy because my canotomy is there. There is the space that I'm gaining. And then you leave the dura over the brain. You must know how to deal with the venous bleeding of cavernous sinus. You can release all the nerves. This is not my idea. The releasing of the nerves was published first for William Caldwell, 2006. He talked about Dolenz, Hakuba, and Kawase. This is a very good paper. You must read this paper. And he published again the results in 2019. I agree completely. You need to decompress the nerves. And then we use this philosophy for the Mi Plata. First, the Petroclival we published in 2019. And now, finally, we published, and I showed you the Mi Plata one. And what's the difference? Because what I'm talking to you is the same that everybody. When you use a transcavernous route, okay, you release everything. First, you take out the dura propria. After that, you open the oculomotor membrane. You expose the fourth, the third, the carotid, the trigeminal nerve. After that, you deal with the venous bleeding, and you take out the dura in the back in order to get to the posterior fossa. You need to take out the Kawase triangle and the porus trigeminus as well, because there's nothing there. Okay, if you open the Philgan fissure, you got exposure of everything. It's very good approach. And then the difference, the classical cavernous sinus and roofing is only on roofing. Here, we take the dura in the bottom. When you take the dura in the bottom, you can see everything in the posterior fossa. For example, to Meningioma, I'm going to finish with this. This is the Mi Plata concept. This is the much easy one. Because, for example, in this case, this is a small Meningioma, but I want to preserve the trigeminal nerve. If I go for the retrosigmoid approach, it's hard to find the fifth nerve because it's in the front of the tumor most of the time. And then I go for the middle fossa. Here, the Kawase triangle is intact because the tumor is small. And then again, mini-terional, orbit, zygoma. But we use the extradural corridor. Please, if you use the microscope since the beginning of the surgery, you don't need to open wide the bone flap. And then I want just to show you that you put a couple of stitches in the dura, you use a lumbar drain, you can even drill the porus trigeminus, drill the Kawase triangle, and you preserve the trigeminal nerve, and you take the tumor in the posterior fossa. Look at this, preservation of the trigeminal nerve is very important. And then here is the carotid, and you have the posterior fossa, B1, B2, B3, trigeminal root, and just a little bit of retraction. Of course, something in the orbit is here, but it's not enough to put in danger your surgery, because your surgery is there, the point of interest, like endoscopy, you see? And then we have the drilling, the internal meatus almost opening. Of course, if we think about the tumors make the work for us. For example, this is a recurrent chordoma. Just I want to show you about this patient. What? Look at this. I just opened the dura in the temporal side of my approach. This is the normal anatomy in a preparation, and only using the tumor we can see. We can see everything. Sixth nerve, trigeminal nerve, fourth nerve, basilar artery, vertebral artery, contralateral vertebral artery, hypoglossal nerve. You can see everything. Here, this is the AC green because this one is the petrous carotid artery. And then, if you said to me, what the limits of this approach? You have no limit because the limit is provided for the pathology sometimes. Okay, look at this. We can take all the tumor. And everybody said to me, no, you need to go for the posterior fossa. You don't need, because you are in the posterior fossa. That's the thinking that you must have. The tumor put you in the posterior fossa in the first place. And finally, this is nothing to do with the cavernous sinus. It's very similar that the case was shown by the professor from New Delhi. Very nice case. The only difference between him and me is I use a minimal invasive route, but on the outside, in the inside, is the same. This is a huge epidermoid cyst. Look at this, temporal everything. And what I did in this case, the same surgery. Again, I went for the extradural route. I cut the meningoorbital band, like everybody who talked before me. the Kawase, the Hakuba philosophy. I release everything, release the optic nerve, release the carotid, and then you can see here, I start to opening the cavernous sinus. This is the optic nerve. I leave the dura over the brain to protect. I'm releasing the carotid. I release the third. I'm going to release the fourth. This is the posterior bend of the carotid. This is the sixth nerve because I put the fibrin glue before. This is the petrous carotid artery or intracavernous carotid artery, sorry. This is the subdural one, the third nerve, the irrigation of the nerve. And then we keep opening the dura. We're going to release the fifth nerve. This is the porus trigeminus. I'm going to take out as well. And then we went to the posterior fossa using the middle fossa. Look at this. I'm using here a little bit amount of fibrin glue because I had a small bleeding. The most important thing, you must use only 1 cc. Never use a huge volume because that is dangerous. And then this is the same surgery. I'm not going to show this because it's not interesting. And finally, look at this. The brain is protected. Remember that the brain have a huge portion of the tumor. This is the fifth nerve, the fourth, the third, the carotid, the optic. Everything released, no problem. I can show in the surgery as well the sixth nerve, not here in another portion of the video, because remember the tumor gives you the space. And then this is the same view that anatomy you can reproduce in your surgery. And you must remember your surgery is in the bottom, not in the outside. Okay, this is the CT. This is the MRI of the patient, just to show you that no tumor left behind. And this is the last case I'm going to show you because it's a very interesting case. This is the first case that I used Mi Plata concept because I was forced for the pathology. And then what happened? A huge subarachnoid hemorrhage on this patient. I got a dissection, complete dissection of the superior cerebellar artery in this patient. Look, I'll show you this. This, I'm going to move this, sorry, because it's difficult to see here. Yeah. Look at this. Look at this. It's a dissection. The patient have 2 bleeds. The endovascular was impossible to cannulate the superior cerebellar, and the aneurysm was huge. Fortunately for me, the patient had a small infarction of the superior cerebellar artery territory, and then I don't need to do a bypass, but I can do a bypass if needed. I will show you. The surgery is so good. And then this is the 3D. The same surgery again. Mini pterional, mini pretemporal in this case. We go for extradural route. We take out the anterior clinoid. Why? Because I want to have a free carotid and a free third nerve. If you don't take out the anterior clinoid, it's impossible to release the third nerve because the third nerve is in the roof of the cavernous sinus. It's very important, the anatomical concept. The anatomy here is very important. And then I open the dura in the bottom. This is the carotid. I'm going to release. This is the optic nerve, the carotid. This is the trigeminal nerve. I'm going. It's a lot of bleeding because the patient have a subarachnoid hemorrhage. And now we have everything released here. Look at this. Fourth nerve, aneurysm, fifth nerve, third nerve, carotid artery. Look at this. Then you have all the pathology. And then I have the basilar artery. I have the posterior cerebral artery. And then I use a low profile clip. I designed this applier. This is a Peter Lasik big clip. This is a flexible and rotatable applier, and then you don't need room for the clip. And then we have proximal clipping of the aneurysm. After that, I went and we did the distal clipping of the aneurysm. If we need a bypass, we can do a STA, superior cerebral artery bypass. I take out the tumor, the aneurysm, sorry, and I said to biopsy, all the lesion. Look at this. We take out the tumor completely, the aneurysm completely. And then we have preservation on everything. Carotid, third nerve. That's why I take out the anterior clinoid. We don't need to take out the posterior clinoid because we came from the lateral side. Okay, we don't need to open the Sylvan fissure. We don't need to expose the brain. We don't need nothing of that because we are working using extradural corridor. And look at the end of the surgery. I just pull out the dura. and put a couple of stitches, and we were done. And then this is the AC green. This is the CT after the surgery. The complete exclusion of the aneurysm. This is the clip proximal and distal, of course. And finally, this patient, she need a shunt because the hydrocephalus, but the patient is perfect now, no deficit. And I think the approach was really minimally invasive because we exposed nothing and the patient is cured for the pathology. And then the Miplata is that, is using the neuroanatomy, is using the ideas of other people in order to have a less invasive way to do the same surgery that everybody do almost in the same way. It's just a way to do less invasive for a faster and better recovery for the patients. Thanks to my fellow, I want to invite you. This is the last Latin American Congress that were held in Chile in 1998. This is where my Professor Evandro, Professor Yasaki, my chief. This is me when I was young. I'm not young anymore. And now I invite you to 2024 that the Latin American courses will be held in Chile. Thank you for your attention.
Thank you very much for that brilliant presentation, Yohei. I would now ask whether Luis is around.
I haven't
Is
seen
Luis
Louis.
still?
No, I haven't seen Louis.
Yeah, Luis had gone off to operate on a posterior fossa AVM, and he had messaged me. And I don't think he's finished till now. I have messaged him, but I haven't heard from him. And Tetsuro, it's a crazy time for him. It's 2:30 in the morning for him. So obviously he has cases. So we will have to call it a day today. If there are any questions or comments, you are free to ask in the next 10 minutes perhaps. And after that, we'll call it a day. It was a brilliant conference. And we all learned a lot as far as, I mean, as much as we lectured, we learned. So thank you very much, all the guys who's done this talk. And if there are any comments or questions, please, you're welcome to ask.
They want to know about the fibrin glue. Everybody wants to know about the fibrin glue. You need to separate between normal cavernous sinus, pathological cavernous sinus. Okay, when you have a meningioma, you don't need fibrin glue because the meningioma is in the cavernous sinus. Okay, when you have a trigeminal schwannoma, for example, a huge one, the trigeminal schwannoma most of the time make a compression of the cavernous sinus, and you don't need as well to you don't need to take out the anteroclinoid. The trigeminal schwannoma, you don't need to take out the anteroclinoid. It's a main difference with the other pathologies that we talked today. It's much easier to trigeminal schwannomas, okay? And then when you have a normal cavernous sinus, the first thing you're going to do in the surgery is take out the anteroclinoid. And then when you take out the anteroclinoid, you made the same thing that Michael Lawton showed, and you made a little hole between. Sometimes it happens when you take out the clinoid, of course. When you don't have the hole in the oculomotor membrane, you made one in between the third nerve and the carotid. And there you put a small amount of fibrin glue, always maybe 0.2 millimeter is good enough. After that, you do the peeling, okay? And sometimes you put fibrin glue between B1 and B2, and sometimes between B2 and B3. But most of the time, the cavernous sinus never go through B3. Almost all the time is in between B1, B2, and B3. But you need to see in your patient. It's different in every patient. And then you need to be careful, because if you have a huge superior superficial symbiotic vein, you cannot put B1, B2, and B1 and B2, because it's going to have reflow of the fibrin glue to the superficial symbiotic vein. Okay, you need to see that in the angiography before the surgery. And that's the point. It's better to put between B1 and B2. And the last one is the most difficult, because you need first to occlude the superior petrosal sinus. You need to do that. You need to put Surgicel there, because if you put just fibrin glue, it's dangerous. You put Surgicel, the Surgicel makes some tamponade, And after that, you reinforce with fibrin glue. And finally, you have the Parkinson triangle. And the Parkinson triangle, what I do, I tell you all the secrets, okay? I put Surgicel first in the Parkinson triangle. And then I put the needle of the fibrin glue through the Surgicel. I cross the Surgicel and I put fibrin glue and wait for 5 minutes. And after that, I take out the Surgicel. And the fibrin glue make you a real wall of fibrin glue that avoid the bleeding, okay? But what you must not do, not use 3 millimeter or 3 cc of fibrin glue because it's dangerous. I never seen in my patients problem with the cavernous sinus thrombosis. Why? Because I am always concerned to use a small volume of fibrin glue. Okay, I must say to you, one time I put fibrin glue between B1 and B2 without an angiography, and I put a small amount. Okay, everything okay. I opened the dura, and the fibrin glue were in the superficial sylvian vein, 1 or 2 or 3 millimeters inside. Nothing happens. But after that, now I'm very careful, okay? Because one thing is nothing happened with the patients, and other thing is nothing happened with the veins, okay? There's a paper from the Japanese from 2017 that 25% of the patients change the venous drainage of the temporal lobe after use of fibrin glue. But it's an angiographic change, not a functional change. Nothing happened. But I think that the key is the first papers from Larry Gamshekar and Ari Krish and Yuha, the amount of fibrin glue. You always, I think, maximum, you must use 1 cc in all the cavernous site, no more than that. That's the only advice that I can give you.
Yeah, one more thing about the fibrin glue is probably the applicator, the original applicator that comes with the fibrin glue. At least in India, is useless. I mean, it's a plastic applicator, and it's not going to be of much use. So one of the things you should do is you should have these needles which are blunt, which can go into any space, and which has various shapes like end curved, straight, and these needles are very, very useful to apply the fibrin glue to various small, narrow places. Any other questions? If not, we've had a lot of comments saying how excellent this session was. I'm very proud of all the speakers. When somebody is asking which triangle have to open to go to the basilar aneurysm, well, you really don't need to open any triangle for most routine basilar aneurysms, but for a really low-lying one, maybe you will have to start opening the triangle between the 3rd and the 4th, and then the 4 and the V1. What will you say, Michael and Yohei and Jim? Any other suggestions?
Did you see the question, how can I protect the superior petrosal sinus? Is that appropriate, that question?
Yeah, the superior petrosal sinus is usually, I mean, when we have drilled the Kawase triangle, I generally open below and above the superior petrosal. And then I earlier used to put clips, but then I found out that it is taking space. So now I bipolar and open. And but if we are not opening below, and as in me plata, where we're not opening below and above, and we're not cutting the tent, then you can make a small opening in the SPS and then keep on packing Surgicel. This is one way. Maybe, of course, it is very dangerous to put fibrin glue into the superior petrosal sinus. That should never be done. Either bipolaring or suturing. Many people use many things, clips, I mean, Liger clips and cutting. I believe I'm quite okay with the gradual bipolaring and then cutting. I don't know how Jim, Yohei, if anything, any comments, Yohei or Jim?
Yeah, for the superior petrosal sinus, I just simply bipolar it, and sometimes if it's still bleeding, I can't shut it down. I'll inject very little Surgiflow, but very gently, just to occlude, a few millimeters of that sinus. Like Ike was saying, you don't want to powerfully inject any injectable sealants into that, because that can eventually go to the transverse sigmoid sinus and then go anterograde to the heart. So, that can be potentially disastrous. So you can inject just a little tiny bit just to slow it down and then pack it off and coagulate it. Secondarily, you can always ligate it too with clips or sutures.
Yohei, Ashish, Michael is here. Yohei and Ashish.
Like James said, for example, sometimes you have this huge superior petrosal sinus. Huh? And what I do is you always must use the dura mater, because you put a little amount of Surgicel. When you use the bipolar, this shrink because of the coagulation, and the piece of Surgicel that you put is going to stuck in the hole. And then you must put the Surgicel, leave half of the Surgicel, I don't know, free in the field, half inside the superior petrosal sinus, and after that coagulate. And after that, I cut it and I leave, and nothing happened. But the important thing about the superior petrosal sinus is it's impossible to open the Meckel-scape if you don't control the superior petrosal sinus. That's important, the anatomical concept, because I saw people who think that they can open the Meckel-scape and they have the venous bleeding and they don't know what happened. What happened is named superior petrosal sinus, and then when you go to the Kawase triangle, you need to coagulate there, and after that you need to coagulate medial to the geminal nerve, and that's how you have control of that bleeding. It's very important. It's something basic, but most of the people fall in the surgery in this kind of basic things because they don't have the training. They don't went to the laboratory to see what the neuroanatomy.
And us asking, the neurosurgeon from Germany asked another question. For basilar aneurysm, only you drill the posterior clinoid and dorsum celli only? Does that make sense?
Well, you don't really need to drill the PCP in most cases of basilar. In my experience, there's no need to. There are very few cases that you need to drill the PCP for. And dorsum celli, we don't drill the dorsum celli for basilar. I mean, you have to understand which perspective are you coming from. So Yohei comes from a quite lateral perspective. So you come from the roof. I mean, when you're doing a half and half approach, you're coming above from the roof, which means you're dissecting sylvian, you're taking the anterior clinoid. And if you're doing a transcavernous, using the cavernous sinus as a corridor, you're coming down from a lateral corridor. You're coming quite lateral. So if you're coming, for example, if you're coming subtemporal, you're still coming from a lateral corridor. But here you're swinging to the side actually, and you're seeing only one P1. And you don't have that perspective of two P1s. So depends on which perspective you're coming from and how high or how low is the aneurysm. So, but you never have to drill the dorsum celli, and very rarely you have to drill the PCP. So if you are very slow about, earlier people used to cut the third nerve, cut the PCOM, and sometimes yes, PCOM may be necessary, but most of the times no, not really actually. So maybe Ashish and Yohei, and is Michael around? I mean, he's
on the screen, but he may have stepped away.
Yeah.
There's another comment, from a Latin neurosurgeon, Dr. Perez. Somebody use bone scalpel to drill the clinoid, or is that considered dangerous?
Well, we used to use the 2 millimeter and the 1 millimeter drill. You must understand that when you do the PCP drilling, if you touch the dura underneath, you're bound to have a lot of venous bleeding. So this is one thing that you have to remember. So a bone scalpel, the tip is not very small, that's the thing. So we've designed this scoop with the reciprocating. So we've designed a scoop which has a very, very small tip, and it cuts like butter. So this scoop we use for PCP drilling, but otherwise I generally use the drill, the 1 millimeter drill. Maybe Yohei and Jim and Ashish can probably tell what do they use.
Yeah, that's a great question. I haven't used the bone scalpel or the ultrasonic aspirator routinely for clinoidal bone drilling. I just don't feel that it has the same tactile feedback that you have with a spinning diamond drill. There are anecdotal reports of thermal injury to the optic nerve, so you have to be aware of that when you're decompressing the optic roof and drilling the clinoid. I think the advantage of using the drill in a diamond burr, you have to use a lot of copious irrigation. And I think the advantage is when you're doing the eggshell technique, you can feel when the bone gives. And if you're using good technique, you can preserve the surface of the soft tissue on the other side, namely the optic sheath or the carotid wall. But you have to be very careful. I don't know if you can reproduce that same tactile feeling with the bone scalpel.
Yeah, I think I agree with Jim as well as Saipe that the drill, a fine drill, gives that haptic. It gives that that feel. I still, whatever bone cues I've used them for removal chondrosarcomas and all, which I showed. They're still a bit coarse. They're not those fine. So I'm not very happy using them at the ACP or the PCPs.
One thing to add is with the drill, you can control the speed of the drill with your pedal, especially when you're getting right to that interface of the soft tissue, perhaps the wall of the carotid or the optic nerve sheath. You can control the speed and do very gentle sub-millimeter by sub-millimeter shaving until you get it to that eggshell thinness to reflect off of the soft tissue. And I don't think you can do that with the Sonopet tools.
Well, we had designed something called a scoop. It looks just like an ice cream scoop, but it's based on the jackhammer principle, or otherwise the reciprocating saw principle. So what it does is it starts vibrating, and unlike a Cusa, because it's a mechanical drill, you can change the torque, you can change the frequency, and bone removal becomes very, very easy with this scoop. And we're trying to get monopolar current or a coablator into it so that it can be used also for very tough tumor removals as well. So this is something that we have designed, and the prototypes are ready right now. So when we are using it, we have used it in a few cases, and it's excellent. So this is something that we may show you in a few months' time once we perfect it. So this is far better than this, gives the haptic feedback as well, and you can change the frequency, you can change the torque. And since it's shaped like a scoop, like an ice cream scoop, you can really shave off whatever tissue you want. You can really shave it off. So this is something that I would be happy to showcase later on.
Okay, Marcius Benigno Marquez asked, once I heard from Dr. Mura that the matchstick drill bit causes less heating than the diamond one. Is that correct? You're muted, Dr. Mura.
Well, Yohei, they're asking whether you had mentioned once that the matchstick causes less
I don't
heating,
use it.
obviously.
I sometimes I use the sonopet to finish the I agree that you don't have the feeling with the sonopet, but you have to be careful with the sonopet, because if you must maintain the sonopet isolated in the back for any structure, because the people think because of the shape is only going to take out the bone in the front. No, because it's vibration. Then you put, for example, against the trigeminal nerve, your trigeminal nerve is going to disappear, even if it's in the back. And then you need to be careful with that, because you can be in trouble with that. But for example, for me, and I saw the first time that the Yuja used it, the sonopet. For me, for the posterior clinoid, I think it's good. And when I want to take out the porous trigeminus, because there's nothing there, it's good as well. You see, because the good thing about the sonopet is you don't need to be concerned to get the helicopter problem. You know the helicopter problem? The helicopter problem is you got anything in the field with the drill is going to work like helicopter, the nerves, the cottonoid, and everything. And I saw that disaster. And then for me, it's very traumatic. It never happened to me, but it's very traumatic to see when a surgeon get a cottonoid, for example, with the drill. It's terrible because everything disappears. The arteries, the nerves, everything. And then the only good thing about the sonopet is you can avoid that because it's vibration, but it's not as safe as you think. You need room to put the sonopet as well. It's not easy.
Okay. Now, thank you very much. We've had a fantastic conference. Thank you, everybody, for the wonderful lectures. We hope to have another conference in the next couple of months. We will have another conference on another topic. So till then, goodbye, and thank you very much for attending.
Thank you, everybody.
Thank you.
See you next time.
Bye-bye.
Thank you. Bye.
Thank you.
Bye.